Welcome back to the Stay Broke podcast. Today we're sitting down with Courtney Barrett, founder of True Insight Direct Care, a healthcare provider focused on a more personalized membership-based approach to medicine. Courtney, welcome to the Stay Broke podcast.
I appreciate it being here.
A few things, I've been hearing these a lot, and I feel like a lot of people don't know this stuff about our healthcare system, that we're spending $6 trillion a year on healthcare. We have the highest obesity rate for adults at 42%, the highest childhood obesity rates at 21%, the highest maternal and infant mortality rates of any first world country. 70% of the population is on one prescription, 50% is on two or more. 80 and over, 91% are on multiple medications. Like, what is going on with the healthcare system?
Let me tell you, these numbers, while surprising, they're almost not. I mean, America is great when it comes to, you get hit by a bus, you need some crazy brain surgery, acute care needs, surgeries and investigational medicines and all of that. They're great at. When it comes to preventative care, we are terrible at it. And I think that literally is the difference. We are so reactive as a country with even just insurance companies. We're just reactive. And that's not really the way to do healthcare.
Yeah. And I definitely I got a lot more questions about that, but I'd like to start off with just who are you and where are you from?
So I am a born and raised kind of country girl from upstate New York, suburbs of upstate New York. My parents were both just high school graduates. Really just grew up on a river, actually. Dirt road on a river, if you can imagine that. So I didn't have a lot of family in medicine. It was actually almost a fear of my father's that he would not be able to provide education. So my parents both did not have the opportunity. My father actually didn't know that even college was a possibility. It was simply, you graduated high school, you went to work type of thing. And so when I was a little girl, we would often go to dirt track races. And I can remember, and it's a funny story now, but I remember my father being like, what do you want to do when you grow up? And I was like, I want to be a race car driver, Dad. And he took that and ran with it. So my parents had both set aside, like bonds that would come due when we were 18, 19 kind of thing. And they knew back then that, okay, each of our kids has about, $18,000, $19,000 for school, which is not sufficient. You know what I mean? And he pretty much said to me, well, if you get a scholarship to college, you can take that money and buy yourself a race car. And it was almost that dare that led me into just like studying. And obviously, that fell to the side and things like that. And I just had that work ethic really from my father. I'm very much my father in a young woman's body kind of thing. Characteristics, personality, everything. I'm my dad in a nutshell kind of thing.
Yeah. Yep. Sounds like we grew up in the same place. I'm from Western Pennsylvania, so not too far away. But okay. I grew up in a small town, dirt road, same thing. I grew up at the dirt track. And what was it? Mercer Speedway, in Mercer County, Pennsylvania. And I spent every weekend there. I'd have to work for my uncle. My cousin and myself would work for my uncle during the week doing scrap metal so that we could pay for our admission to get into the pits to be his pit crew on the weekends. Nice. And then because I was talking to my son about this yesterday. He's like, what'd you want to do when you were my age? I said, I wanted to be a race car driver. And I stuck with that all the way up until I was 16 and then decided to join the military at 17. And that was the year I was supposed to start driving my first car. Yeah. Chose a different path. And I'm glad I did, but I can definitely relate. I'm curious about, was it a small town, I'm assuming?
Yeah. Big high school, but where I grew up was definitely more kind of suburban / rural. Just a street of about 10 houses and, maybe 4 or 5 kids. And we just grew up going into the fields and going through and riding bikes down, deer trails and things like that. Yeah. And just, jumping off ropes into the river kind of thing.
So I've been thinking about this a lot the last couple of months, from a healthcare perspective of growing up in a town like that. I don't know if your town was similar, but in my town, everybody in my family's having surgeries all the time. They're all on medications. There's a lot of, growing up, I saw a lot of doctor shopping and and it led to the way I took care of myself when I was younger to, instead of going to rehab. I did surgeries that I probably didn't need to have and didn't get the results I needed because I didn't do the follow-up rehab the way it should be. And it's like, that was just how things were. And it's still like that every time I call back home. Somebody's sick or somebody's going in for another surgery or something's going wrong. And it's just like a lack of education and the lack of resources to know that like surgery shouldn't be the first option. Medication shouldn't be the first option. I didn't know. Was it similar where you grew up?
Not exactly. I mean, it sounds very rural-esque, but we were very close. Like it was a suburb, really just about 25 minutes to downtown Syracuse area in upstate New York.
Okay.
With that, but I definitely hear you where even just in general, like small town or big town, I think we just jump to the immediate fix.
Yeah.
And my family is relatively healthy overall. My father and mother, not many medical problems, but I had medical problems growing up from almost a young age. And pretty much I was essentially the black sheep of the family, if you will, for medical problem on medical problem type of thing. And I think that's what, partially why I got into medicine, but also just my interest and things like that with a community group when I was in junior high or middle school, finding a youth group that was involved with the local ambulance corps and kind of getting involved in emergency medicine and that kind of field. And that's kind of what spurred me forward.
Okay. Yeah, I remember because we only had a couple doctors. We had a small hospital about 30 minutes away. Our closest like real medical care was in Pittsburgh, which was about 80 miles, 90 miles away. So that was only for like real serious stuff. If somebody was going down to Pittsburgh, they were real sick. Like we grew up, our town's about 700 people and it's still about that today.
Oh, geez. Yeah, it's much smaller than I was. Geez, I think my graduating class was about 700.
Ours was 100 people, and it was the same people I went to elementary school with and graduated with. There might have been a few that came and went, but it was pretty much that's how it was.
Yeah.
So how'd you progress through high school and decide on medicine and college? And
so interestingly, my parents, having not gone to college themselves, were very much like, you're going to college. You really need to figure out what you're going to do. College is the only way you're going to be successful. Which I'm thankful for that. I don't think I could afford to go to college nowadays. If I was born 30 years later, I don't think I would have been in the same situation. But at that time, it was very much like, this is really how you're going to be able to be successful and survive and things. And when I got involved in that youth ambulance corps, it was actually through like the Boy Scout program of America, like a co-ed explorer type group. And that got me into EMS and got my brain ticking down that road. And I always kind of had that science, mathy kind of brain, if you will. And from my experiences there, great mentors at the ambulance corps. I actually got my MT certification at the earliest age you could get that. And then later on got my paramedic certification and things like that. So in between actually being away at college for undergrad and coming home, I was working as an EMT and eventually as a paramedic. I took a couple years off before I had gone to medical school and was working as a paramedic during that time. So great experiences there and really just solidified that I love the science and applicability of medicine, but then also just that human connection. Yeah.
How was medical school? I know. So we had a guest on that was from the former USSR, and she was on the path of medical school, and then realized that it was all like just studying out of books and not like really getting in and like seeing the cadavers or doing the things. It was all memorizing. Like, what was your experience with it?
So I actually went to the Lake Erie College of Osteopathic Medicine up in Erie, Pennsylvania, and the difference there was they actually had like a lecture-based program. They almost had like an independent self-study program, and then they had a problem-based or PBL, problem-based learning program. And I initially started in the typical lecture program and soon was like, hey, I want another option. And I did the program or the PBL program and the problem-based learning, and that was a unique approach. So even during your first 2 years, which is really just the nitty-gritty, the biochemistry, the really nuts and bolts of everything, obviously anatomy and physiology. I worked with cadavers for anatomy and physiology, so it was that direct, really true versus, some people do like online cadaver type of things. But that really solidified really kind of bringing in that human part of it. So the problem-based learning, you would be presented with, Joe Schmo presents to your office with this complaint. And as a small group of, 6 to 8 kids with a mentor, a physician mentor, we would work through these problems, and we would actually have to, okay, what are you going to do next? What question are you going to ask? Here's your answer. So page by page, we get the answer to what we wanted to investigate. So everything from lab work up to, the questions we would ask, the answers would be given to us page by page as we work through an entire case. And when we did that, typically cases would take 2 meetings to work through. And after each meeting, we would pick about, 50, 60 pages out of our assortment of textbooks to read to give us the foundation for those cases. And so each case would be about 100 to 125 pages of material that we'd read to support the case. And we work through modules. So like each semester, essentially, we would have 6 or 7 cases. And so, over the course of that, module of work, we would have a variety of chapters in a textbook. And as each group, we would pick the material we were going to study for that case, study it. And then each of our testing at the end of those modules was a selected test just for that group. And it sounds just kind of foreign to do it that way, but it was unique in the sense that it programmed you from day one to think of it clinically as a person, their circumstances versus just like, we're going to read biochemistry 101 and then we're going to read biochemistry number, chapter 2 kind of thing. And over the course of doing it that way for 2 years during those, that foundation of medical school, we actually read all of our textbooks on average about 3 times through, cover to cover. And it was a unique way in doing it, but it really drove home the applicability of the basic sciences to the problem at hand. So moving forward, we transitioned into 3rd and 4th year on clinical rotations very seamlessly because we were so used to ordering this and ordering that, and this is what I want next, and this is what, this is the differential I'm making up in my mind, versus the students who were just lecture-based basic sciences really struggled with that transition. But throughout it, we always had that foundation and always thinking on the basic science foundation of the problem at hand kind of thing. So it definitely, and more schools have taken up that approach with problem-based learning and things, but that really kind of set the tone and made the first 2 years much more enjoyable to a certain extent because you could actually see where you're going with it. But the first 2 years, it's arduous. I would say that a lot of people would probably drop out of medical school if it weren't so expensive because you have that like, oh my goodness, what am I getting myself into? Let's just back out and quit kind of thing, just because of the overwhelm. But you're like, well, I'm in too much debt right now. I can't even just, step out or step away kind of thing. But with that, they use the analogy of drinking through a fire hose. Like you're learning so much that you are literally just chugging through a fire hose of knowledge and you just got to keep on gulping kind of thing. Just stick with it. It's not necessarily about being smart as much as it's determined and just that dedication in and out, day in and day out kind of thing.
What degree did you go for specifically?
I did a DO degree, so Doctor of Osteopathic Medicine. So it's essentially the same background and knowledge base as MDs, but we actually get extra training in osteopathic manipulative therapy, or OMT. It's easier to say OMT for the tongue twister. And that's really essentially, it started actually before chiropractic came along, but chiropractics tend to do a lot of the HVLA or high velocity, low amplitude popping, cracking, and just mainly focusing on the spine versus our modalities incorporate not only that similar type of popping, cracking mechanism, but a lot of soft tissue techniques with muscle and fascia and bones, and not just the spine. So we really treat the entire body, and it's kind of that added bonus. So when you've exhausted everything on the traditional type of approach, it's that accessory type of modality can really help people out.
What about so for most small businesses, the thing you hear that's the difference between success and failure is customer service, but in your industry, it's bedside manner. Like, how do they teach that in school?
That's a great question. I think you can teach it by really just not verbal teaching, this is what you do kind of thing, but more so demonstration. There's a difference between, someone who goes in the room and just stands there, their arms crossed, talking to someone versus actually just, pausing, sitting next to them on the bed, say in a hospital setting, for instance, and just actually learning about the person. Yes, they're there because of a disease or a circumstance or a medical issue, but who are they as a person? Even just that brief moment in asking, oh, who are these people with you? Oh, is this your family, your granddaughter, your friend, whatever? Learning about them and actually just, treating them like a person first. I think that's a huge part of bedside manner that oftentimes is lost, especially because we're so rushed. In the traditional system, there's no time to do anything. There's barely time. Ask a doctor the last time they ate lunch. They probably can't remember. Yeah.
Interesting. I know it's like nurses are there for bedside manner. Doctors are there to do their job and come in and out as quickly as possible.
Yeah.
Yeah. So where'd you progress from there? Did you have to do residency or like, what did that look like?
Yeah, it's interesting when I went into medical school, especially a lot of my prior mentors in EMS were like, oh yeah, she's going to be an ER doc. She's going to go something like that. And at that point I was like, I'm done triaging. I'm done triaging people for like small things that don't belong in the ER or things that actually do and need, quick attention. And I found myself actually kind of in this polar type of state where I really liked outpatient medicine, really that opportunity to just connect with someone, with ICU medicine, which is like polar opposite. I mean, if you think of ICU medicine and very procedure heavy and in and out and people like life and death and that, transition and, you have to act quickly and, drop a central line or do a procedure at bedside and all of this versus outpatient medicine, which is very much, day in, day out, following up and things like that. They're pretty much polar opposites. And the difference for me is because each of them really piqued my interest, but in almost very differing ways. And I had approached a close mentor who really saw my potential in ICU medicine. And I said, Dr. Nichols, is there a program out there? I understand, residency might be working nights and things like that, but is there any, permanent days or permanent nights positions in ICU? And he looked at me and said, no. And that eventually pretty much said, okay, I'm going into outpatient internal medicine. And internal medicine is just very broad. You go into internal medicine before you might specialize in cardiology or rheumatology or nephrology and things like that. So that's really the foundation into a lot of specialties. And, so that was always maybe I would find a specialty really intriguing, but I didn't want to narrow down into just one specialty and really kind of hang my hat there versus really having a broad knowledge about a lot of things. So I ended up, going down into outpatient medicine.
Which is like family medicine? Is it the same thing?
Yeah. Internal medicine is essentially, your adult population. And then you can actually get, internal IM peds. You can actually branch into IM and peds and then family medicine. Family medicine also has the component of like OB care and things like that. So there's a lot of different, even just, that initial step into internal medicine or a form of it, if you will.
So I'm assuming you can't just decide, all right, I want to do internal medicine, open up your own practice. Did you have to like work for another doctor that focuses on internal medicine or? So
the residency program for internal medicine is 3 years. So you graduate medical school and so you're a doctor at the end of medical school, but you still have to complete a residency in the US. And so you still have at least a minimum of 3 years after that. And so that's internal medicine training. And then you can actually go out and practice as yourself, not supervised by another, attending, so to speak, as you do in residency. So you have the autonomy to place orders and things like that, but you're always supervised by someone else with many, many years of experience as a resident. But once you're outside of residency, it's you and only you. And that's a unique transition in and of itself.
So where'd you go from there, from after residency?
I actually, my husband had family in this area. So I did residency up at Southwest Michigan University, and which was a fantastic program, incredibly supportive program, because many residency programs can be very, very cutthroat, if you will, and very, very a struggle in and of itself to make it through residency. But it was an incredibly supportive residency. And from there, my husband had family in this area, actually down in Cary and things. So this area drew us because we grew up in upstate New York. We went to school for medical school in Pennsylvania and then in Southwest Michigan. So we just circled the Great Lakes and all of the lake effect snow and the 20 below. And at that time we were like, all right, we're kind of done with the 20 below. If you could have snow at 70 degrees, it would be fun. It would be exciting. But the 20 below is what killed us. And so he had family in this area, and we didn't like necessarily the economy of upstate New York and things. And And this economy was flourishing. And so it was really just a great spot, tons of opportunity as far as healthcare and things. And so that's how we landed here. And then our moms actually and our families moved down to join us and be the grandkid. So it worked out well.
Yeah, it's a different experience up there with the lake effect snow, especially you were closer to it than we were. We were kind of on that cusp where it would hit us, a lot of the year. And like people were like, oh, it'd be fun, living in the snow or playing in the snow. But like there's years where you're 6 months into it and you're like, is it ever going to go away?
Yeah.
That's what I remember, trick or treating in the snow.
Oh yeah. And you had to gear your costume to whether or not you could fit a snowsuit underneath it. Yep. There were no princesses in my neck of the woods. No, there's no Jasmine from Aladdin or anything. Yeah.
I moved for the same reasons. There's not much to do up there, and the weather was a big key in moving down here.
And even with just the warmer temperatures and like global warming kind of thing, you used to get like a great snowfall, a solid winter, but then you had so much warm up and down. Then you got just the muck of the muddy, snow, salty, slush garbage that it was not even enjoyable at some points. So, yeah.
I remember we took my wife took the family up for Christmas a few years back. And my wife had lived in the north for a short period, and she's like, so she thought she knew what cold was. And we went up there when there was a nor'easter coming in, and like, I remember one of my kids, her favorite story to tell about it is we were going from the car into the house, and my daughter starts crying, and she's like, am I dying? Because like that shock of that air hitting you with the snow, the wind is like, my beard would freeze within about a minute. And I was like, no, this is what I'm talking about when I'm talking about real cold. Like,
So you definitely kind of laugh along with me in this area where people cancel school because there might be a storm.
Yeah.
Kind of thing. Yeah. I used to walk, of course, growing up on a dirt road. Actually, our school bus did not go down the road at that time. So we had to walk probably a quarter mile up to the bus stop. And at the end of the road, there was a nice, good slope. And so oftentimes the school bus would have to wait several minutes because the ice coating that hill, if you didn't get traction on enough edging to make it up to the top, you were just sliding down time after time, just trying to get on the bus.
Yeah, we had the same thing.
My hair would freeze in the morning. I'd take a shower, go outside, my hair would freeze, your nostril hair's freezing, that kind of thing. I hear you there.
It's funny because like going back to like the places where I used to swim and stuff, like we were swimming when it was like 79 degrees in these strip mines that are probably 60 degrees, and it was just normal to us. Like that's what we swim in, and we were fine with it. Now you go up and put your toes in the water, you're like, what are we thinking?
Oh yeah, for sure.
So what led to you deciding to open your own practice?
Oh my goodness, that is not a one answer question, let me tell you. So when we first moved here, I started working for a corporate entity out in Wakefield. And it's interesting because over time, there's just a lot of just different tidbits about this direct primary care idea. In fact, when I first started at the office, many people had said, oh, Amy and her friend left not too long before you started, and they're doing direct primary care, and they're so happy. And I was like, interesting. And someone I had met in the urgent care had come up to say, oh, hello, nice to meet you. I work down in urgent care, and you're one of the new physicians at the office. And I met her, and shortly after meeting her, probably maybe 6 months later or so, she ended up opening her own direct primary care office. So you look at kind of the course and the timeline and things, and I always had this idea. I was always very independent growing up in general. And so I always had this idea, what if I had my own practice? And my husband and I would always kind of toss it out there here and there, but it was never really in the cards yet. Obviously, you graduate medical school, you have hundreds of $1,000s in debt, and you just can't really make that leap. And when we had moved to the area, we had a 3-month-old. And so we always wanted someone at home with the kiddo and not necessarily two people working and just to pay for daycare kind of thing. And so he was staying at home with the kiddo. And so I was the primary breadwinner at the time. And fast forward a couple of years, I'd gone into a private practice, not yet a partner in the private practice, but had that. And at that time, that lasted about a year before I actually had to take my own medical leave. So I was out for a couple of years. And when I returned to medicine, I didn't start right back in primary care. I actually worked for a startup, very preventative focused startup out of Durham, where we would talk with patients and really get into the nitty gritty of education and lifestyle management and really preventative focused on your core issues, your obesity, your heart disease, your dementia risk, all of those kind of things. And those meetings with people being able to talk about all those things that I never had the time to talk about in traditional healthcare really said to me, yeah, you need to go maybe into direct primary care. And so my contract ended with them because I was a contract physician at about the end of around 2024. It was interesting because different things, my husband's job at that time, he had gone back to work when I was on my medical leave. And so he was working dispatch for Wake Forest Police. And his job was changing a little bit where instead of a rotating schedule, he was going to end up being all nights. And I'm like, okay, young family, dad working nights all the time, mom back in medicine. This is not going to really work out all that well. So some doors in life closing, some doors in life opening, and just a lot of different, just little tidbits over friends and family and things. And I went home to my husband one day in November 2024. And Randy, I kid you not, I looked at him, I said, you know how we've been talking about this and talking about that? And I think God's just been planting seeds. And what if we opened our own direct primary care office? And he looked at me and he said, sure. And I was like, what? Seriously? All right. Seriously? Let's do it. And we literally just hit the ground running. I mean, when I make that analogy, there is that analogy, I didn't make it up, but the fire hose of medical school, the fire hose of business school, because you don't learn business in medical school. They don't tell you how to run your office. You get no business education whatsoever. And at that time, it was like, all right, Business 101, just every resource we could find, whether it be a small business at a local community college class, tons of small business, and you might know of these, but like score.org and just mentors in the business world and the how-tos of it all. We just started running rampant. Every moment we had was in a small business class or, getting this information or filing, learning how to file for an LLC and with the Secretary of State. And I mean, it was just, we just locked in and said, we're doing this. And we just ran with it. Just held fast and ran.
Let's talk more about that, because one of the big things we try to tell people about is the resources that are out there. And a lot of people don't know or understand that there's lots of good resources. Like, how do you decipher between what's legitimate, what's not, decide what resources to utilize, and what were some of the best ones that helped the most?
I would say we really just hit home with it, like the local community colleges and the small business associations, because that was just a well-known, trustworthy source to start at. And I actually was doing investigation of, even from the medical standpoint, what EMR system am I going to use? What kind of like commercial space will we need? And as I investigated that, I was learning about different EMRs and actually got paired up with a gentleman through my EMR system, actually. He was like, hey, why don't you talk to this other doc who had experience with a different EMR and then ours and things like that. And he was just, a wealth of information. When it comes to the direct primary care community, there is a large community, and it's not a community that's like, okay, well, this is mine. This is how I do it. You can't have it kind of thing. It is literally like, what do you need? Let me give it to you. We are, that online community across the nation is just incredibly supportive. So tons of resources on that front from the medical standpoint. And then from the business standpoint, I actually learned from that doctor that was just randomly given, just a pairing of information from our EMR source. And he told me about score.org as a national free mentor pairing program, essentially. So they put you up, and I'm not sure if you're aware of it, but really just, what kind of needs do you have? What kind of questions do you have as you're looking to launch your business? Let's get you a mentor in your area. So if you're in San Diego, someone local. If you're in Raleigh, someone local, and things like that. And that was a huge resource. And just classes, just every free class that was out there, whether we had done a class similar to it or not, it was like, let's just, a different perspective, somebody new, a different perspective. Same material, I don't care. Let's see it. Let's hear it. Because the more you hear it and the more consistency you hear, the more you learn it, the more you know that it's, true and accurate and the best way to go about things and whatnot. So we just took it all in as much as we could.
How long was that period?
So I mentioned coming home in November, and we really just kind of hit the grind over the holiday season into December. And that put us into 2025, and we set a date to open in May of 2025. So May 12th of 2025 was our opening date. And so we locked that in because everyone said, if you don't lock in a date, you're just going to keep on putting it off. And so we said, all right, boom, locked in that date and just put our put our feet down and just never stopped running, really, when it came to whether it be a random mutual colleague we'd never met in person who was offering to help online, another direct primary care colleague, local direct primary care offices, just talking and talking. And it was interesting because before we made that leap, I actually had thought about, well, what if I joined another DPC practice? And there was one locally that was hiring, and I got on the phone with one of them one night. And, and they were an office that did family medicine, but I'm not family medicine trained. So I don't do like the little toddlers and things like that. And so, and when I was talking with her and discussing things and saying, well, I don't know if it's, I really like how you guys practice. I like your mentality and like your focus of the practice and things, but I'm not sure that we're best suited for each other. I don't have that background to be able to cross cover pediatrics, the little ones and everything. And she kind of had that similar sentiment, like, hey, like we'll kind of hear each other out and see what kind of paints the picture, how the picture goes and things. But she literally said to me, she said, Courtney, whether or not you join us at our office, if this is something you want to do, you can do it. She pretty much just said, listen, if you can make it through medical school, you can run a business. You've suffered through medical school. You made it out alive. You can pretty much do anything if you put your head to it. And that kind of struck a chord. And here we are.
So you mentioned earlier that you kind of had it in the back of your mind about possibly having your own practice someday. Did you have that same like entrepreneurial spirit as a kid?
Not necessarily. I mean, somewhat, I was always very independent. I always, if I wanted to do something, I always thought, yeah, I can do this. Let me just do it. My dad wasn't a huge entrepreneur. He actually worked at the warehouse at John Deere in Syracuse, New York. And but, when I was a kid, he had a small like snow plowing business and some small like lawn mowing business and things like that. But nothing really extravagantly huge as far as needing PR and marketing and all the really detailed aspect of that. It was more so like mom and pop kind of like, let me have the side gig for extra income kind of thing. It wasn't like a full on type of entrepreneur type of background. Yeah. Okay.
What about, so whenever you came up with the idea, were you still living in Cary or had you already moved up here?
Oh, no. So my husband had family in Cary, but we actually, when we moved, we actually moved to Wake Forest. And we moved and bought our house sight unseen. And just a kind of a video with our realtor kind of thing, and but it was a blessing. And interestingly, when I compare the move, ending a job, starting a new job, selling a house, buying a house, moving with a 3-month-old and 3 different dogs, and a whole house full of stuff, I would do that 1,000,000 times over than look for commercial space. That was the hard part of everything in our business 101 as we just got everything underway and doing it all. Was the commercial space. And even just knowing that when we settled on a spot and we signed that 5-year lease, even as we approach a year, and even from day one, I was always like, okay, what's our plan in 5 years? Because I know that time flies and it's not an easy process. So even from that point, the minute we even signed the lease, I was like, okay, what's next? Because that I would move and do all that 1,000,000 times over than look for commercial space again. It's arduous for sure.
Yeah. When you're signing that first 5 or 7 year lease, it seems like forever and time passes so quick.
Oh, for sure. Yeah. For sure.
What made Wake Forest the right place to set up your practice?
Well, initially, actually, it was the job that brought me here. I mean, certainly the area brought us here and the family brought us here. When I solidified that job in Wakefield and things like that, it kind of put us in that Wake Forest area. We knew we wanted a slightly larger yard. We didn't want to be like stacked up housing kind of thing. And so we have a neighborhood now that we each have about an acre or so. And so that was like spread out enough and enough where we weren't too close in town. And so, our house is technically Wake Forest, but we're very, very much like we're outside the town of Wake Forest. And even our address is like the western part of a Wake Forest address, actually just over the Granville line, actually. Oh. So we are barely Wake Forest address homeowners, but we love this community, and it has been a great place to start a small business. And I think that if anyone started a small business, I mean, the Wake Forest area is booming for small business and so supportive of it.
What were some of the biggest struggles in, like, say, the first 6 months of trying to open the practice?
Honestly, just kind of getting the word out and really kind of welcoming that networking. I'm a people person. I enjoy getting to know people, but when it comes to walking into a room full of people and trying to get into a conversation, I'm very much like that reserved, like, hi, I'm over here. I don't know. Can I just jump in, or where do I belong here in this room full of people? That's very much me. So really just kind of having that confidence to really just, hi, I haven't seen you before. What's your name, kind of thing. And really kind of welcoming that and getting into that, I think, was the biggest step. Yeah.
I struggle with that too. That's why I like doing this. I like one-on-one interactions. I'm not good at working a room.
Yeah. It's definitely a skill, and it's learned, and you just got to do it more and more and more to feel a little more comfortable each time. But I think that was probably the biggest personal and business kind of transition, if you will.
So about your practice specifically, is like concierge doctor and direct care the same thing?
Very different, actually. Okay. So I would say the access to that physician is probably the overall common point. Concierge is much more expensive. Oftentimes there's thousands of dollars in retaining to be a part of the practice. And they often also bill insurance. You often have, per visit copays or deductibles still apply you're paying each time you go and things like that, or different procedures and things like that. You're paying for kind of all the nuances. So it's really mainly the access. For direct primary care, it's a monthly or annual fee if some people choose. And it's really just all inclusive. There's no per visit charges. We don't also bill insurance. And the reason we do that is because that's actually what makes it affordable. We can have that low monthly or annual fee if some people choose, because of the fact that we don't have to employ 3 people to bill insurance and deal with the insurance reimbursements. The reason that traditional medicine has such a time constraint is because the insurance reimbursements are so low that physicians and practices have to see 20, 25 people a day just to pay their staff and keep their lights on. And so when you eliminate that low reimbursement and you just give a single fee, you can actually have that time back. You can, have that relationship back. You can really just save people a ton of money because they're not dealing with copays and deductibles, and they're not dealing with a ton of out of pocket. And the benefit also is, we can run the office just as how we see fit. So I am so passionate, and the more we talk about it, you'll probably see my face light up crazy and be like, what's wrong with this girl? But I love saving people money. So when I'm able to meet up with a lab that will, give me a great cash price, and I can actually forward that cash price right onto my patient, and, the same thing, get medications at wholesale pricing and really just pass that along, a minimal markup for shipping or the bottles and all the stuff that goes along with prescriptions, to pass that along to a patient and save them in comparison to GoodRx, save them in comparison to cash pay prices elsewhere. That is like a huge, huge passion of mine. There's this part of me that is very ethically bound. I don't understand why medicine has become such this profit-driven, profitability on people just wanting to be healthy and well. There's other cash-based, offices out there that mark up labs and mark up procedures and just profit incessantly over people just wanting to be healthy and well. So if I can set a reasonable monthly fee where it's cheaper than a cell phone bill, cheaper than a storage locker, and people can access me as often as they need to, and I can save them money so they can actually look at different labs that, they can change what they do or how they approach their lifestyle or their health in general, and they can afford the medications to stay healthy or hopefully make the changes and come off medications, the more the better. And so, when people first come to the office, when we first opened, I had, a basic mini pharmacy, of your common blood pressure medicines, common, depression meds or antibiotics and things like that. But what I found is when someone would come to me and maybe I didn't have a medication they were on in stock, I would say, okay, well, what are you paying for it? Oh, you have insurance? Well, what's your copay? Oh, your copay is $10? Well, I can get it for you for $6. Or, hey, you don't have insurance and you're paying $40 for that inhaler? Let me get it for $10. And so I just actually converted into, as I brought on a patient, if I didn't already have their medication in stock and they needed it, and they're paying a certain price and I can beat that, by all means, let me add it to my order. And so I would literally meet with patients, and when they would first meet with me and I'm getting to know them and I'd find out what medicines they're on, I would literally just say, okay, well, what are you paying for that right now? Let me see. Let me bring it right up in front of the patient, like, because I have that time and I'm not dictated to a 15-minute visit. My visits are, an hour with patients. My first visit's often 90 minutes to 2 hours because I'm getting to know them. I'm having conversations, learning goals, learning like what does their support system look like and everything like that, who they are as people. And so I'm loving that. It's really just been a fantastic transition from the way the system operates to working for that preventative focused startup in Durham to now being able to really just own it and take it, as I see fit. And what's nice about North Carolina is as a physician, I can have a dispensing license. So I can have that mini pharmacy in-house and save people tons of money. And it makes me happy and excited. I had a patient come to me where she was paying close to $120 for a 3-month supply of a medication that had just recently become generic. And I said, okay, wait a second, I can get that for you for $70. And I'm like, woohoo, 3 months for $70. Here's, out the door, we're saving $50. And then recently I found a different supplier and found I could get it to her for $50. And I'm like, I'm celebrating. I'm in my office going back and forth with my husband. Or like, tossing medication names. Okay, well, hang on. What's the next one? What's the next one? Yeah, save, enter, add that to the cart, add that to cart. We're saving. Yeah. And so it just gets me giddy really to just provide great care and give people what they deserve and be able to have the time to listen to them and all of that. It's just a great pairing. I don't see myself doing anything else. Like this is just going to take me to retirement.
Why do you feel like this type of healthcare is so unknown to the general public? Because it's like, the normal working class, it's the hospitals, the doctors, and now the urgent cares.
Yeah.
Because the doctor's offices are too busy. And so a lot of people are going to urgent care for all their needs. And then you have like the famous people or the rich people that are going the concierge route and they're getting the best health care. But like you said, that's unaffordable for most people. Yeah. And there's this other option, which is why I was so curious to sit down and learn more about it, because it's something that you don't hear about on a regular basis.
It's interesting because the word's slowly getting out there, but what happens also is, for instance, in this area, there was a news article when one of the other practices had opened probably 8 or 10 years ago or so. But now if you try to get just like some PR out there, just to let people know of this option, we as the physicians in the practice kind of have to pay for it. You know what I mean? And there's not a lot of return on investment for marketing in the direct primary care world, if you will. When you look at just all the stats and the evidence and just what other people have experienced around the nation and things. And so really it is about just doing podcasts and getting the information out there and doing newsletters and just word of mouth and really just to let people know that healthcare is affordable. Right now we're in this point where there's almost no non-corporate offices. Corporations have had to really just eat up the small mom and pop shops and things like that and the small independent offices because the reimbursements every year go down and down and down from insurance and the overhead just continues to rise. And so the average Joe just can't survive taking insurance on their own. But we're also in this conundrum where, well, I have insurance, I want to use it. And, or people just feel that they have to have insurance, that if they don't have insurance, they're just going to go broke. Because if you go to a corporation, even if you pay cash, if you have insurance, the charges are marked up for insurance. And it's really about getting that information out. The way the system is set up is just backwards. And so essentially, insurance way back when insurance kind of came about, it was like, hey, healthcare costs are getting kind of pricey. We need insurance. Okay, then insurance came and it was like, everyone's going to be saved by insurance. And then, you get the corporations who, they have to be in network with insurance and the people and the providers have to be in network with insurance. And then, if you're taking that insurance, then they're going to negotiate what the lowest rate possible to pay you because they're a for-profit system. And so you take a for-profit system and what's the bottom line but the dollar? And so over time, like what's billed to insurance is this inflated, like anywhere from 40 to 400% inflation on the charges that are billed to insurance. And so if you have insurance, boom, this is the cost. But if insurance doesn't cover it, you're stuck with that cost. But if you just paid cash, you could have paid here. But if it's billed to insurance first, they can't revert to cash. And so the whole system is just, it angers me. I mean, it's just so flipped upside down. It really is. And so people really only know, well, I'm in the US, I have to have insurance because healthcare is unaffordable. But if we actually take insurance out of it and return to a relationship, I mean, I think of myself as like the doctor in the 1970s, you know, like you'd bring your little tote bag, go to someone's house and, you know everybody, you know, the dynamic, you know, the relationships, you know, kind of the ins and outs of the family, and you treat them and you move on kind of thing. If we can bring back that free enterprise to healthcare and bring back some competition and drive down prices and, you know, really take the insurance out of it. And certainly, you know, for folks, and my family is very much in this situation. Like if you're on a really expensive biologic medication or you're in the middle of a really expensive, you know, cancer workup and diagnosis or something like that, yeah, you're probably going to need that insurance. But the aspect is the system's so backwards that everything's inflated to bill insurance, because then insurance will say, okay, well, if you bill us this much, then we're going to get the bill for this much and we're going to pay here. Okay, you know, all right, we'll agree to that price. But if you just pay cash versus having something apply toward your deductible, especially with these high deductible plans, the premiums and the high deductibles right now are strapping people. People are carrying insurance because they're scared they're going to end up with appendicitis and need that coverage. But, you know, they could actually pay cash and save money and not be down that road. It's really just backwards. Yeah.
Yeah, that's the issue that we're having. We're a family of 7. I have 5 kids, and it's like we look at it at the end of every year, especially the last couple of years since I've been learning more about the healthcare system and the insurance system. And we keep talking about just getting rid of insurance because we take the highest deductible plan, and then, you know, by the time we pay for the insurance and then we meet our deductible, and if, you know, there's a change in the policy at all, then the deductible starts over.
Yeah.
And so that's a battle, but it's still that thing in the back of our head. Like, all right, what if something serious happens? You know, out of 7 of us, there's bound to be a medical emergency at some point. And like, how do we afford that?
It's interesting because you bring up that family of 7, and I knew a family of 7, 5. No, I lie. Family of 5. The 2 adults, 3 kids, young family of 5, maybe like early 30s or so. And the husband's insurance, employer-sponsored insurance, was still going to cost them about $1,400 a month. And they were a healthy family of 5. Not only that, but they even had a family history that was really relatively healthy. So here you take, you know, like Health 101 kind of thing, like really no high risk, anything that they were aware of, you know, let alone, you know, driving a car into a river or something, you know? And they were paying $1,400 a month. And eventually they said, why are we doing this? And they stopped, and everyone's like, you're crazy. What if your kid gets sick? What if you end up in the hospital? What if? And they were like, we'll just deal with it. Lo and behold, one of their children ended up in the ER. And when they were getting discharged from the ER, she tells me this story, that they were getting discharged and the bill was, you know, $6,000 or something. And she said, well, I don't have insurance. And I said, well, hang on a second. Okay, your bill's $1,300. So literally her family could have gone to the ER every month for a year for a similar cost problem and still saved $1,200 in that year from just the premium alone, not even including the deductible and things. And so a lot of people, you know, they think that health insurance is the only answer or corporate medicine is the only answer. Yeah, when you do need a hospital system, when you do have appendicitis, you need an emergency surgery. Yeah, you are, you know, you're in the hospital system. But oftentimes we think of the bills as being these inflated bills that end up going to insurance. And then insurance is so happy. They're like, look, we saved you X amount of dollars. And well, that's inflated dollars too, you know, versus if you actually just paid cash for your surgery, probably could have paid like $3,000, you know, versus the $15,000 that they billed insurance. And so it's really just getting that information out there. I am such a fan of health shares. Are you aware of health shares at all? Mm-hmm. So health shares, you know, long ago, they were often very like religious affiliated health shares or Christian health shares and things like that. And there's a variety of them now. There's everything from secular health shares to, you know, lifestyle health shares to religious affiliated health shares. And what's different between health shares is that, you know, you kind of have this monthly And they have different terms. So they don't have premium or deductible kind of thing, but essentially, you have a monthly cost, say, $500. And you have an initial out of pocket. So if you end up in the hospital with appendicitis, you might have to fork over $750 or $1,000, kind of similar to deductible, right? Your initial out of pocket. But then it's covered. But the difference is actually all the costs. First of all, they're nonprofits. They're not for-profit entities. And when you end up with a bill, you submit that bill as a cash pay bill. So you don't get this inflated charge. The health share covers that bill at a cash pay rate because they don't have a contract with the hospital system. They don't have all this inflated in between people and all these layers of administration to pay for. And so, that's an option where, and there's so many different health shares out there. Every little health share has a different, what they do or do not cover, or your initial out of pocket amount, or, is there a maximum lifetime cap or those kind of things. But those are options where if you're relatively healthy and you're not currently on a very expensive needing insurance to really kind of spread it out across a group of people, you can pair direct primary care where you're very proactive, preventative, and you can save those urgent care or ER needs because you have a close relationship with a physician and pay $100 a month for that membership and pair it with a health share where you're paying $300 or $500. And look, you're already saving, $800, $900, $1,000 a month because you're pairing those services. You're being proactive where the system's not proactive. You don't have anybody dictating your care in that situation because there's no insurance guy saying, no, you can't do that test. We're not going to pay for it. Or, and you're not working with a corporate entity where even if you wanted to pay cash for that lab, it's going to be way expensive and marked up to the high heavens. If you actually work with someone that you have a relationship with who has these connections and has the ability to, go with a bunch of other doctors around the nation and get certain lab prices or get certain medication prices and things like that, then we can pass along those values and really pair with people to save them money, to save them the aggravation. And that health share can always be back there as the coverage that if you have an event and you're stuck going to a hospital with some crazy surgery, that will be covered kind of thing. So it's really about taking this whole focus that America's been so insurance driven and needing insurance and everything like that. It really takes you to really open up your mind and really pivot to looking at healthcare a totally different way.
Because it's scary. I mean, it's crammed down your throat and you're told that if you don't have it, then, you're going to die essentially, and nobody's going to help you.
Yeah.
And it's kind of what they tell us.
Yeah.
And it's hard to get good information other than that because like you said, marketing and everything else, there's, what did we say earlier? $6 trillion industry. They don't want to let that go.
Yeah. And the thing is too, Randy, is that when it comes to, people worrying about medical debt is the leading cause of bankruptcy in the US. But I beg the question, is that medical debt because you had a catastrophic need, or is that medical debt because you had an insurance with a high deductible and high premiums that strapped you month to month? And then you get this high deductible and then you're, you know what I mean? That's what I beg to answer. Where is this true medical debt coming from? Because I would argue that it's not what we think,
Right.
Because if you truly are paying a cash rate and things like that, certainly there are instances where, you can end up in ICU and have, millions of dollars worth of need. But for the average Joe, what's the reality of some of this too, And I think that really we just need to pivot as a nation almost. And there's so many broken aspects of healthcare. I don't think I'll ever be able to, think of, or, we're not going to fix everything. And direct primary care doesn't fix everything, but it solves a lot of the headaches. It really brings things affordable for people. It brings that relationship back. It brings that time back. In a 15-minute visit, when I was working in corporate medicine, a 15-minute visit, by the time the nurse brings somebody back and rooms them and asks the questions that I'm going to repeat anyway, and yada, 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 and checks all the boxes so insurance is happy and corporate's happy and things like that. And to actually even just talk to someone, introduce yourself, ask the right questions, ask more questions to clarify things, make sure the patient understands what question you're asking and you're actually getting the answer that you need to make the decision, to form the differential, to talk to them about what you're thinking in the differential and why you're headed a certain direction. And, why, by the way, this is what we need to do to look at this further or treat this further or X, Y, and Z, and talk pros and cons and side effects. Come on. Are you kidding me? That's not possible. And do that 20 times a day, 25 times a day. And we wonder why our physicians don't have bedside manner left. Right. Because they're strapped. You know, when I was working corporate, I would go in the office at 6:45 in the morning to start at 7:45. And I would finish, my last patient would be at 3:45 in the afternoon. And I would be at the office clearing my in basket until 7 o'clock at night. And I would go home and I would just fall apart. Because even in those moments, you know, my Saturday is taken up with documentation. Documentation for me? No. Documentation for the patient? No. Documentation for the insurance company and for corporate to get 5 extra cents? Absolutely. So, you know, when we look at all these different factors that play a role, it's so convoluted and it's so frustrating for the physicians as well. I mean, we end up being slaves of the system. We come out of school with so much debt that oftentimes we can't even possibly open our own business from the start unless, you know, someone gifts us a wealthy family of money kind of thing. And it's one of those things where you're essentially trapped as a physician, and the patients are trapped too, because they're locked into this focus of healthcare being insurance and that they can't afford it unless they have insurance and things like that. But then they're also taking home these crazy bills when insurance didn't cover it. And guess what? They're stuck with that inflated insurance cost. It's insane. You know, I actually talked with someone just yesterday who has insurance and recently had a mammogram or a follow-up study for a mammogram, something of that nature, and ended up with a $600 or $700 bill for something that wasn't covered. I had an MRI myself, and then I got a bill for the gadolinium. It was ordered as and approved as an MRI with gadolinium. But somewhere in there, someone decided, well, the purpose of that MRI, great, but we're not going to cover the med needed for it, you know? And it's left and right, and it's happening to everybody. It's there's not a day that goes by, Randy, where I don't feel like someone tells me another story, which makes me literally think it's crumbling in front of us. You know, it's crazy.
I agree 100%. I hear lots of stories, like some of the ones you've told. I've heard other people telling them, people giving accounts of having the same paying cash versus using insurance. You said you've had some medical issues throughout your life. Do you carry insurance?
So actually, yes. Simply because, so my medical history is intriguing. When I mentioned my dad working for John Deere, it was a blessing because this was back in the day where you could work for a company and there were pensions or there were true benefits and things like that. You know, that doesn't even exist, you know, almost like you could work up through the company and go from the janitor to the CEO kind of thing. But anywho, John Deere being a company really supported their employees. And so my dad had great insurance, and I was diagnosed as a type 1 diabetic at the age of 9. And my dad had actually at one point said, do I work here? Do I work here? And that company actually, one of the companies he almost worked with that was not John Deere, almost like had actually left the area. And he's like, goodness gracious, I'm so blessed to have worked for John Deere, got that good insurance and things. And so I was a type 1 diabetic growing up. And I'm just a hoopla of autoimmune disease. So I've kind of got it all. And throughout the course of, going through school and having insurance while I was in school and things like that. And then being employed by a corporation that they also contributed insurance. But even then, funny thing is I paid about $1,200 a month while I was working in medicine for a corporate entity and had their insurance. And I was still paying that much a month for insurance. And I've had other medical issues that have really been something where now, because of the medications I'm on and things like that, I kind of have to continue with insurance. So unfortunately, like our family alone is a family that, you know, we're kind of stuck with insurance for various reasons from prior existing health problems that we know that we're going to need expensive medicines and things like that. And unfortunately, I passed that autoimmune bug to my son. So he's on an expensive medication. So we're actually like that subset of direct primary care. Like if you ask an average direct primary care doc, who do they see? They say direct primary care and a health share. You know, at a summit conference last summer, my husband and I attended, and there was a panel of folks, and someone asked, like, what do you guys do with your insurance and things like that? Because as a business owner, you understand this. When you go out to buy insurance, and you're like, okay, we're on our own now. We don't have an employer-sponsored plan. We are the HR, you know what I mean? And then you go and you look at the prices, and you're just floored. You're like, my goodness, I got what? How much a month? And I'm just starting a business, you know? And so for our family, we do carry insurance. But we also know the value of paying cash for something. So, and we know that what's available out there. We had that insight to know that, well, you know what? Actually, don't use the insurance. I'm actually going to pay cash for that. You know, our deductible is X, Y, and Z. If I want an X-ray, I'm going to pay $45. I'm not going to send it I'm not going to apply it toward a deductible when I'm going to pay, $250 out of pocket toward my deductible for that kind of thing. And so knowing the system definitely helps. And I think that's the biggest thing is the transparency of the system is not there. People don't know what this goes toward. They don't know who's making the decisions. They don't know why, the doctor's rushed, or they don't know why all this, the background noise, you know what I mean, of who truly has control. And it's nice to step outside that. And when I talk with patients, and I always do like free meet and greets, people can just hop online and do a meet and greet to see, hey, is this something that would work for me and my family? I'm always open to that. And in fact, just telling people what I'm able to do from my side of it and how the system's set up, I mean, opening eyes is just a part of it that I enjoy doing. It's why I enjoy, working with different podcasts and things like that. Yeah.
That's one of our hesitations too. My wife has an autoimmune disease, but it's so rare that there's no real treatment for it. So she goes through trials occasionally. Every few years, there'll be a new treatment for it, but it's never anything that's worked out. So it's like, all right, if something does happen with it, like we want to make sure that we have insurance so that she can get the treatment that she needs. Mm-hmm. So.
In my dream world, I would have, like a national insurance where it covered the crazy expensive medications and the crazy expensive diagnosis. You don't know what kind of card you're going to pull up. You know what I mean? Like everyone has been dealt different cards and, by no fault of our own, those kind of things. Genes play a role in this and that, but, anyone can end up with a cancer. I mean, if you live long enough, sure, like with that. And ultimately, if we could spread that out across the nation, and then for your day-to-day healthcare, your generic medications, your this and that you just paid cash and brought back the free economy for competition to drive down the price, I think we'd be so much better off. If people knew that they had an option to go to a doctor and either pay a monthly fee and have unlimited access, or go to a doctor and just pay $100 versus, feel like they're going to go to corporate, and corporate, you don't have control over the cost. You go there for a cold and it's going to be like a $250 charge, because it's billed at the insurance rate and things like that, whether or not you have insurance. And even the cash pay rate is not, the doctor doesn't even have control of what they're going to charge a patient. So if a physician is able to survive on their own and have a relationship with people and know that, like, hey, Johnny, I realize you just lost your job. Like, I can see you for free. It'll be okay. Like, we'll even up later on. You know what I mean? Those kind of things. Like the doctor back in the 1970s did, and have more autonomy on that and be able to have cash pay rates and drive down the price. Because, there's a lot of cash pay platforms out there. There's these online people doing GLPs and hormones and left and right. There's tons of access if you want to pay the price for it, pay $300 a month just to get the option to maybe do a medication through someone online. Or there's random offices that are cash pay offices that are, offering random small services that people want, but they're jacking prices up and they're jacking, the access cost and things like that. But if you brought back more cash pay offices that start competing and driving down that price, you're going to get results. It's free market, economics 101. Not to say that I'm an economic pro by any means, but, I just love to think outside the box, whether it be a patient who presents with an interesting complaint or whether it be how to go about things differently to make it easier for people,
I want to talk about some specific classes of medicine a little bit later, but you touched on like the doctors and how they're kind of being pushed to produce a certain way. And then, what's the term? I just had it in my head. But I want to talk a little bit about malpractice insurance and forcing doctors to treat a certain way. The way I understand it is that doctors, sure, they're free to make their own decisions on how they treat a patient, but if it's not in the standard of treatment, then their malpractice might not cover it, which the way I understand it is if I come in with high cholesterol and they put me on a statin, instead of sitting me down and saying, hey, let's look at your diet, let's look at your daily exercises. And if they choose not to do the statin, now that person dies, now they're open to malpractice suit. Am I understanding that right? So
to a certain extent, yeah. And that's the downside to medicine and things like that. For instance, if there's a certain
standard of care.
Standard of care, exactly. Yeah. If there's a certain standard of care that says, according to this algorithm, the best evidence suggests statin. Let's use that as an example. You brought that up, right? So best evidence is statin. Then on our side, like when we work in corporate medicine, there's always that liability. If something goes wrong, who's liable, right? And that's been pushed so much in America's history, right? And it's a huge factor in the cost of medicine and things. And like when I work in corporate, it's a matter of, well, is this my decision or the patient's decision? And what are their subsequent labs going to look like? Because there's so many, how do I say, like just all these voices, if you will. You have the insurance voice, you have the corporate voice, you have the, like what are the metrics looking like, evidence-based metrics, and how many of your patients are compliant, and how many patients, have an A1C of this, or how many patients have their blood pressure controlled and not controlled, and that's going to dictate, some of your bonuses or this or that. And what it boils down to, it really, there's no evidence to suggest that you get better outcomes with any of that, and when you make everything based on metrics, it drives the conversation, and when it comes to corporate medicine and malpractice in general, like, if a patient refuses the statin and then they have a heart attack and die, okay, they bring the doctor and say, hey, it's your fault kind of thing. Essentially in that, the documentation has to show like, hey, I offered him a statin, he refused, we talked about the risks, yada, yada, yada. And generally speaking, overall, that's sufficient. You have to document that these guidelines really suggest that these are the benefits, these are pros and cons, and yada, yada. But really, it's a patient's decision. But when you bring up that point, it also drives home some of these metrics that corporations look at. They look at A1C metrics in diabetics. They look at blood pressure metrics and things. And so, when I used to work in the system, they were very, they portrayed this, we focus on quality. So we want you to hit quality metrics, not necessarily the quantity of people. Yet your census still increased and the number of people you'd be seeing a day still increased. But, we want you to meet these certain metrics. So we want X percent of your patients to have a flu shot. We want X percent of your patients to have a good blood pressure control. We want X. But why does that reflect on me? Or why is the insurance paying you more reimbursement because of X metrics and things like that? Because frankly, I can't hold my patient's hand and walk them home and force feed them their blood pressure medicine. And frankly, like, you're your own person. I can lay out all the information there and I can explain the pros and the cons and the whys and the why nots and things, but you are your own person. There's a thing called autonomy. They teach us it in medical school. The patient has the autonomy to refuse, but then you get working in corporate and all of a sudden they're like, well, you have to have X amount of percentage of this to get this little financial incentive, reimbursement, whatever, bonus, kind of thing. And so if there's all these financial incentives on the backside, whether it be for the physician or the corporation or the reimbursement from insurance, and there's these financial incentives, yet I just I just finished medical school and they told me that autonomy is so important. Show me, and it's so it's so convoluted in that respect. And yeah, there is that malpractice aspect, but really, that fear and that malpractice fear and things like that, I think is what drives home all this burnout too. Different states have better malpractice coverage or like tort reform and things like that, where, they're not going to necessarily bring someone in front of court and say like, you were completely negligent, those kind of things. And there's some caps there and really kind of verifying the actual complaint at hand and things. And malpractice is in and of itself just a convoluted topic too, I think people are more litigious and things like that with the way healthcare is now, even compared to just having a relationship. I mean, malpractice for a direct primary care physician is often better than malpractice if I were to work at a corporation. Why? Because they've actually started to notice that when you have a relationship with someone and you know each other well and, you're available and there when they have an issue and things like that, it's less litigious. You get less suits and things like that. And so even as a direct primary care physician, malpractice is more affordable than if I were opening my own practice taking insurance. And when it comes to that, it's really, there's so much value, even if you want it, like it's so hard to put a dollar value on relationship, but if you were to, just look at that. when I can talk with a patient and have an hour visit with them. And, I know them in and out, and we've been working together. And even my first visit was 2 hours with them, getting to know who they are and their goals and this and that and what they prefer and why and all those nuances. And we have that relationship where they can call me at 9 p.m. on a random Friday, and I'm going to pick up the phone and say, hey, yeah, I hear you. Do X, Y, and Z, and give me a call tomorrow morning. Let me know how you're doing. Or, hey, let's tackle it this way, and I'll see you bright and early Monday morning when I'm in the office. That relationship and that connection is valuable. And it even goes to show when you look at litigation and things. So, being able to put a dollar and data point on some of that is actually, some of that information is there, and it's intriguing.
So I know we have the choice as a patient, but I feel like most of us don't have the knowledge to make the right choices, especially based off a 15-minute doctor visit and handed a packet of papers to read through and think that you're going to be able to understand it and decide what's best for you. So you're held to the same standard of practice, right? I'm assuming, but does that extra time allow you to better educate your people to be able to make the right decisions for themselves?
That's what bothered me when I worked in the system, because I'm like, so many people would come to me and, random tidbits, it didn't take me long to say a quick sentence, like to tell them, oh, this is what the top number of your blood pressure means. That's the first time a doctor's ever told me that. What? As a patient, and I've been a patient, I was a patient long before a physician. The more I understand, the more I'm invested in my own health. So if I have time to educate a person, educate everything from maybe the medication they may or may not be on to just lifestyle things. If I can actually sit down with them instead of saying, John, your labs look great, but you're overweight, so we'll see you next year. Just eat less and exercise more. Have a good day. Versus me sitting down with John and saying, okay, so this is what happens when you eat this type of food. This is what happens to your blood sugar. This is what happens to the different hormones in your body. That's why you're kind of always hungry a couple hours later. Oh, by the way, if you were to even just eat differently this order, actually, that would actually help how you feel later on in the day, and you'd actually have more energy and not really feel so hungry. And oh yeah, so if you actually did this a little differently and this minor change here. So do you think how about we meet up in a month and see how you're doing at that point? Wow. Because it's not just actually telling somebody what they need to do. It's actually stepping with them through that process and giving them that education, that knowledge, and not just once and have a good day. But when's the last time you heard something once and just knew it like the back of your hand? Not me. Count me out. I have to read something 10 times before it sinks in, kind of thing. And that's way for most people. And so really, people need that person for accountability. They need that person just for routine check-ins and education and true follow-up. And right now, the system's not set up for a follow-up. I had a friend of mine from medical school literally she had a social media post one day because she did the analytics of what her patient census was and her schedule throughout the entire year. So you had, 52 weeks in a year minus 4 hours a week for administrative tasks, which never took 4 hours, by the way. and you had, 20-minute visits, no matter what it was someone was in for. And let's say on average, someone has 1 annual visit and 1 sick care or chronic care follow-up. So 2 visits a year. What could be the max census that I could carry and actually fit everybody in that year? And she pulled out the numbers, and the numbers were something, I'm pulling off kind of the top of my head, but like something like, oh yeah, my max census can be 1,600 patients, something to that effect, right? She actually did the math to figure that out. What's the average census when you work in the system? 3,000. Anywhere from 2,500 to 3,500 patients on your census. How often they come in or whether they're still true patients, that can be, tossed up. But there's a good assortment of people that are regularly seeing you that is well above that 1,600. And oh, by the way, all those messages coming in from those people. But in direct primary care, I can cap at 500, not have all the administrative BS, actually have a relationship. And when my patients need to be seen, I can actually have the availability to see them. No one's going to be waiting weeks and months to get an appointment. When people establish and I'm like, yeah, I can see you next week. What? Oh, you can see me next week? I'm like, yeah, new patient, I can see you next week. When I'm following up with someone, like, hey, we made these lifestyle changes. Let's follow up in 3 or 4 weeks. Yeah, boom, boom, boom. How about this day? Did that work out? Yeah, cool. It's not, I actually missed my own physical one year, Randy. I missed my own physical. Why? I was in the hospital. Missed my own physical. They're like, yeah, we'll see you again. Let's reschedule this 9 months later. I might as well just wait 12 months. I might as well just skip my physical that year, and how much other things are getting lost in that when you don't have a regular physical and you don't have time to actually talk about random symptoms and things like that. The last time I had a physical was like, oh, how are things going? Good. Negative review of symptoms. Well, wait, you never even asked me if I have experienced shortness of breath or if I had a cough or, last time I experienced X, Y, or Z, because there's not time to do that. The physicals, I actually had a lady call and she was asking all these kind of nuanced questions about like, what do you do in a physical? Because she kept on having these physicals that was like a brief conversation and like just listening to a heart rate and saying, have at it, And I'm like, yeah, where's the true head to toe physical and things like that? You can't do that in the time constraints and things. So people have been so discouraged by what they've experienced in the system. And even when people are just meeting me for the first time, they have these questions like, how do you practice? Or what's a typical visit look like for you? And, if I came in with X complaint, what would you ask me or what would you do? Why? Because they've had some cruddy experience and are reflecting on that experience and just praying that I'm a little bit better, that they can actually get the care that they think they should have been getting and haven't been because the system's so broken.
I hope you're enjoying the podcast so far. We appreciate everybody for watching. We appreciate the growth that we're seeing. We're getting amazing guests. We still need to get a little bit more reach to keep this momentum going. So help us out. Drop a comment, like, follow, subscribe, share if you love the content. Help us continuing to get amazing guests with amazing stories and help those stories get around the world like they should be. Thank you, and I hope you enjoy the rest of the episode.
A couple of things you mentioned that I want to touch on. One was, I guess indirectly, but gut health, your diet, and how it relates to your overall health, from everything from, how you're feeling to your skin to blood pressure to, like you said, you have your spikes and knowing how to mitigate those. And then the other thing that I see as connected to it is all these health influencers online, and they're taking all these supplements and like, this is what I do, this is how I look this way. And it leads people to just choose what medications they're going to take. And then we're talking in the vitamin space specifically, but take these vitamins without doing the blood work. You keep referring back to blood work to know what your body actually needs. And my daughter just went through a case of this. She was taking, I forget, I think zinc or something. And she got very pale and her eyes got sunken and her skin was flaring up to like an extreme where they wanted to put her on full-time injections to get her eczema back under control. And we took her to actually to a chiropractor that does also alternative medicine stuff and did some tests on her. And she's like, you got to quit taking this supplement.
Yeah.
Then let's take your blood work. And like, if you want to get it quicker, go donate blood and that'll get it out of your system. And sure enough, that fixed all of those issues just because she was taking something that her body didn't need. And she was essentially giving herself heavy metal poisoning.
Oh yeah, for sure. And actually zinc's one of those, some of these supplements out there, it's like this many milligrams of zinc. And I'm like, someone's going to run into an issue if they're taking that daily. And the thing is I am so pro when it comes to supplements and things. I believe very much in a lot of different supplements and the information while supplements are one of those things that, sometimes there's not a pharmaceutical company behind it sponsoring a study and things like that. So you might not have a ton of data with the study, but we also know that we can look at a certain supplement and say, hey, it has X, Y, and Z potential and it has X, Y, and Z possible side effects and things like that. And and each person is so very different. And so you can't just go to a random person online and say, oh, like, hey, they did this and it worked for them. You might do that and hey, yeah, it might work for you, but that doesn't mean it's going to work for the next person as well, because everybody metabolizes things differently. Everybody processes things differently. I mean, even look at disease process that we know about. We can have somebody, just think of genetics. There's so many different genetics to a person that one person can drink super heavy for 1 million years and never develop a liver issue. Some other guy can drink like half as much for half the amount of time and poof, he's got cirrhosis. There's so much to each person, but if you want to look at a supplement, I always argue supplement or medication, you start one at a time. So if something happens, you know why. And you always say, you start one at a time, and you also look at the before and after, whether it's a before and after and how you feel, or a before and after in labs and things like that. So you want to see or feel a change and know that that's what helped you, or things like that. And I also agree that there's somewhat of a placebo effect too. And if you take something and it's not harmful to you and there's a placebo effect to it, by all means, continue taking it. And on that same notion, like, you have quality supplements out there, but then you have a lot of crud on Amazon that is potentially very toxic and things. And even when you look at zinc, yes, we need zinc, but if you overdo zinc, you're going to run into copper issues. You're going to run into other issues. You're going to run into a whole host of issues, and you're so right. I'm so glad that you saw that and were able to get that help to define that and things. And when it comes to like gut health and things, kind of on that same aspect, what we put in our bodies, and just if you think of the American, just as broken as the American healthcare system is, the American food system is, I would argue, maybe just as much an issue. And really, everything from what you take in and how it makes you feel and things like that. I have a gentleman who has really bad plantar fasciitis, and he can actually pretty much cut his pain in half just by eating an anti-inflammatory diet. Because so many of our medical problems, Randy, I would argue that, at the baseline of most medical problems, the baseline cause is inflammation. And even from a cardiac standpoint, I had a gentleman, a program director when I was a medical student, in a room full of students and residents and other physicians and things like that. And he was up at the whiteboard. And I'll never forget this, because he was like, what's the cause of heart disease? And he got every answer but the right one. And so, like, whole room full of physicians and students training to be physicians and everything. Cholesterol, bad diet, no exercise. Well, like every answer. And he said, you're all wrong. And everyone's like looking around like, oh, come on now. Like the whole cohort of us, someone's got to have the answer. He says, no, inflammation. So inflammation in the vessel and plaque buildup and the whole 9 yards, yada, 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 moving forward. Interestingly, I just attended like a CME, continuing medical education lecture recently about colchicine, which is an anti-inflammatory gout medication that's now having tons of evidence in preventative, secondary prevention and of heart disease and issues. Guess what? Because it reduces the inflammation. And so even, this program director way back when having this insight, and that for whatever reason, it always stuck with me. Like, there's these little moments that just stick with you, and that was one of them. And when I attended this lecture recently, I was like, interesting. Because I heard that like 20 years ago, and look at it come to fruition now in these studies and everything. But yeah, like inflammation and what we're putting into our bodies, everything from the food that we eat to what we're exposed to. And yeah, you're probably going to go berserk if you try to eliminate everything. But to just kind of be aware what you can, maybe what you can't eliminate. You don't want to drive yourself neurotic, trying to eliminate everything. But if you can avoid microwaving and plastic, do it. If you can avoid standing behind a car while it starts up and sucking in all the exhaust, by all means, sure. If you can avoid putting crazy toxins in your body, I'm a full believer in, your body, the miracles that our bodies are. Our bodies don't metabolize a gram of apple the way it metabolizes a gram of high fructose corn syrup that's fake. Like, our bodies don't process a calorie of apple and a calorie of Snickers the same way. I'll never be able to show it in a study, and it'll probably be a gazillion years down the road and somebody might show it. But I argue that gets processed so differently. And even when you look at our food in America and how much sugar is infiltrated and things, back in the day, it was this whole anti-fat thing. Fat's terrible for you. Yeah, trans fat and saturated fat, yeah, they're quite terrible for you, but there's other very beneficial fats. And really, when you look at sugar and the inflammation that it causes and the addiction that it causes, and when it lights up the same area of the brain as heroin, come on now, and so I enjoy those conversations and meeting people where they're at. If they're looking to make certain changes, if they're like, hey, I just don't have the capacity to make this change, but I can make these changes. Let's talk about them and go from there, kind of thing. But you're right on when it comes to gut health and exposures and what we're putting into our bodies, and even just like the mind gut connection and things. I'm totally on board with that for sure.
So they say treating for the deficiencies. That's what you're supposed to be doing with supplements, and you can't do it if you don't know what your deficiencies are.
Yeah, absolutely. And the thing is too, is like, even when it comes to looking at deficiencies, some people, a lot of people might not be deficient in something. And that's where the traditional medicine system fails. It's like, well, the range on the lab says your B12 can be, 250 to like 1150 and you're 301. You're good. I would argue that most people feel a lot better when they're in the 600-700 range or higher, like let's ignore the number for once and actually talk about how someone feels. Let's not just treat the number. I've been in that situation where someone looks at me and says, it's all in your head. The number there on the machine's great. And I'm like, yeah, but I feel like I'm dying. Like, hello, And so, yeah, we have these data points. Use the data points, but just don't hang your hat on a data point either. Like the person is sitting in front of you. And that's, again, when we're so rushed, we don't hear the person sitting in front of us. When we're someone else is already in the room next door saying, I've been waiting for the doctor for 15 minutes and, you're behind schedule and this and that. And that's why people aren't being heard, and that's why some of the issues aren't being addressed. And then you have people, going to social media for their advice because their doctor didn't listen to them or, their ER visit didn't go well and they're still having the issue because they weren't educated or counseled or what steps to take next. And, then we have people turning to online influencers, good and bad. I mean, there's great influencers out there that have a wealth of knowledge, but also you also need someone to guide you through that knowledge too, that can evaluate the different changes you made or what's working or not working and why, or make sure that it's not harmful or harming you in some way. That you can't just do that with an online thing, and you can't just necessarily plug your information at ChatGPT and get even a correct information, correct answer sometimes. And that's kind of where we're at. People are getting so frustrated with the system, not knowing that other options like direct primary care or health shares exist and the nuances of that. And they're turning online and just self-doing it. And, it might work and it might not. But if it might not, it might very well come close to killing you or destroying your body, and sometimes you can't get that back and, those kind of things. So I'm glad that you got the care for your daughter for sure.
Another lack of education from patients is like you talk about inflammation, and most people think of anti-inflammatories and muscle inflammation or joint inflammation. But like you said, people don't realize you can have brain inflammation and vessel inflammation. And like, there's so many other things to it. And like, most of us don't know.
Yeah. Yeah. And the thing is as physicians, I mean, there's not a day that goes by that I'm not learning something new. And even if you look at the history of medicine, especially more recently, the knowledge would increase by like exponentially is increasing, right? But when you look at the doctor back in like 1980 or 1990 and the information that they had to know, like in whatever setting, and then you look at the information now, it's literally an exponential curve. And I'm the first person to acknowledge, like, I'm not going to know everything, nor am I always going to have the right answer or know the answer to whatever XYZ presents in front of me. But I'm the first person to say, you know what? I know my limitation. You ask me a question. It's been a while since I've looked at that. Let me see if there's new data. Or, you know what? This is my experience. But let me check if there's something else. Like that's often how I work with people. And I enjoy doing that, because I'm able to gain more information, learn more information. And the patient knows that I'm not just saying, that's impossible. Nope, that's not going to work. Or, well, that's the way the guideline is. Well, we follow the guideline, but I'm still having the problem. Those kind of things. So I enjoy looking outside the box or saying, you know what? I don't know that answer, or this is where my brain's at. This is what I'm thinking. I know a colleague that I can contact who has more experience and pick her brain a little bit. Let me do that. I actually did it recently for a patient, and I called my friend from actually undergrad who went to this similar school and is a practicing psychiatrist up in Connecticut. And I was like, hey, how you doing? We haven't talked. The last time we talked was on Facebook about 10 years ago. What's up? And it was like yesterday. And just chiming back and forth and presenting a case, obviously no HIPAA information and things like that. Like, hey, I've got this person dealing with X, Y, and Z. This is my thought process. She's like, yeah, I like where you're headed. And you know what? Maybe this might apply. And I'm like, yeah, you know what? I think you're dead on. Yeah, cool. All right. Hey, how much did it snow last week? Like, what'd you get? Those kind. And that's that medical relationship when we have colleagues and things like that. We nickname it like a curbside consult. Like, hey, you have more experiences here, or, you've really delved into this niche of medicine, or you have a ton of patients with that similar condition, or those kind of things. And so I enjoy just reaching out and being honest with people instead of, I know that I'm never going to know everything. And if a patient thinks I'm going to know everything, first of all, I gotta educate them there and literally say, like, your expectations are wrong and this is why. But just to say, you know what, like, I might not know it right now, but I'm going to search for you. I'm going to be your advocate in whatever you're going through, whether that be something that's totally foreign to me or something, that, yeah, I did learn that. And it's been a while since I've encountered that, but let me refresh, and by all means, I'll call you tonight and blah, 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 those kind of things. So, I mean, the medical information out there is just increasing. I mean, each day there's how many new studies? I mean, if I claim to keep up on the studies and claim to keep up on the new medications alone, I mean, I'd be lying through my teeth, and every doctor out there would. If there's any doctor who says I'm up to date on every little thing in my field, walk, run, they're lying to you, that kind of thing. So, yeah.
You mentioned plastic, and that's like a hot topic right now, microplastics. And like, how do you decide, like, because I've been going down that rabbit hole, like, how do you decide which ones are valid or that you should pursue? Like, you talk about the flour that we're using in the process for drying out the wheat and the chemicals involved in that and what that's doing to us, and then the microplastics and all the effects that's having on our bodies. And like, we can go on and on about these things, and it's like, how do you decide which ones are valid that could change your life if you do it or not? And because it's like, oh, you're killing yourself by drinking from a plastic bottle and heating up with a plastic bowl. But at the same time, like, yeah, we have all these health issues, but we're living twice as long as we used to. Mm-hmm. So like, how do you balance that?
Yeah, it's definitely one of those things. And you kind of, there's so much bias in how you look at something too, like, you can say, is that like true causation? Is that correlation? Is that, is that a bias because, hey, we have more information, so we're diagnosing more, but is it truly increasing? We have more knowledge and more data, or the algorithm or something like that, or the metrics to diagnose a problem have changed a little bit. So therefore, is the problem all of a sudden more prevalent, or are we just better at diagnosing it and things? Kind of that same idea with like the plastics or what we're putting in our bodies and things. And really, I always say, like, look at yourself. Like, is this important to me? Like, where's the big data point? I could say, okay, microplastics are, getting into our brains, and microplastics are getting into our organs and things like that. What's the most critical to me? Well, I mean, look at your personal life. Like, what's most important to you? And then say, is that worth changing what you're doing? Is it worth saying, you know what, like, if I'm thirsty and I'm getting dehydrated, I'm going to pick up a bottle of water. Am I not going to do that because there's not a glass to drink it out of? Or, you know what I mean? And so, like, how much of an influence in your life, in your day-to-day life, and your own mental sanity is it going to have an implication versus the long-term risk and things like that? So really, it boils down to each person and really saying, what's most important to me? If I look at the data, how strong is the data? If the data is really strong about, microplastics and dementia, and I already have a family history risk of dementia, okay, like, let me sink my teeth into that and really focus on that, because you're going to run yourself thin if you look at every little data point out there. And I mean, we're just in a world that, like, we're so evolved now. You could argue 5G cell phones and plastic and, metal and, yes and no. And like, what can we truly live without, and what can we sanely live with or without, you know what I mean? And so it really is a personal question, and actually having a conversation, hey doc, what does the data show? Or, what would you recommend in my situation? Because these are my goals, you know what I mean? Because each person's goals, are different in things. And so I would say that answer is probably very nuanced. But just looking at the data and looking at the source of the data and why it's there, or, how strong it is and things like that, because I think we'll drive ourselves nuts trying to eliminate it all. Yeah, but definitely, there's definitely some good, hard, concrete data on microplastics for sure. But it's interesting because the other day I had been drinking out of a bottle of water, and someone had said, I don't know about that, doc. And I'm like, well, it's either I drink out of the bottle of water and I satiate my thirst, or I go for the next several hours without, water, and my kidneys are screaming. Yeah. Like, all right, like, I'll survive, that kind of thing. And yeah, if I'm going to drink daily, I'll drink out of something that's not plastic or those kind of things. Yeah.
Yeah. I think you hit it with understanding correlation and causation. And so people don't look at it that way a lot of times, and that's what you got to look at.
Yeah.
And then also the extremes of it, like there's the leading expert in microplastics. She wrote a book and, all this stuff. And it's like, how does she get her water? They distill it, right? So now you're getting distilled water, and then you're having to remineralize your water so that your body's getting what it needs out of the water. And it's like, this just isn't making sense.
Yeah.
So I don't know.
And then you go to the store to get distilled water. What is it in a plastic bottle?
Yeah.
There's certain limitations that we have and things like that. And really it kind of just boils down to who you are and your goals and things, and kind of just making it applicable and doable,
Yeah.
Yeah.
Another supplement question. So a lot of people, like growing up, it was always, take your vitamin C, all this vitamin C, and your different ones. What are in vitamin D? But what is it? Vitamin D isn't good without K2.
It's still good.
Okay.
There's benefits when it comes to bone health. Vitamin D, like there's implications of having enough magnesium or calcium, drive it into the bone and things. And then K2 to help with those different physiological processes when it's metabolized and really getting the calcium into the bone. And so that's where that's kind of beneficial and things. And when it comes to D, even nuanced things, it's a fat soluble vitamin. So if you're taking it on an empty stomach every morning, you're probably not getting the benefit. And so like take it with a meal so that you are able to, absorb it better and things. Vitamin C is a great one too. And vitamin C has huge benefits for like immune health and things. And I mean, even when I was pregnant and I didn't want to take any medicines, and I was in residency at the time, and I had just a crazy upper respiratory infection. And I was just like, give me the vitamin C, just give me the vitamin C, and just, routinely throughout my day, vitamin C. And then, the next day I was feeling much, much better and things. So, but it's also, what are you going to be supplementing every day versus when you need it, or, certain circumstances and things. Because not all, like you mentioned, the zinc and things like that, some things build up under your system. If you're overdoing iron and you're not losing iron, you're going to start putting iron into your organs and into your vessels and into your liver and into your heart and things. So, just because it's a multivitamin, ultimately, if you eat a well-rounded diet, a lot of that you don't need. And then if there's certain things that you do need, looking at them and actually trending them to see when your levels are at and going from there. Vitamin D is one of my passionate ones, because even the Endocrine Society said we don't need to check vitamin D on labs. And for a long while, insurance has said, we're not paying for vitamin D. It's ironically a more expensive lab. Actually, cash price is about $15. But interestingly, I would argue that even in the traditional sense, like the lab says, above 30, you're good to go. 30 to 100, that's a great range. 31 is a little different than 99, but they say that that's substantial. You're good on your vitamin D. I used to argue that 50-ish and higher, is a little bit better, and even more recently reading some information about like in the 70s and things, because vitamin D is not just good for bones. It's good for bones. It's good for muscle reflex and different mechanisms at the cellular level for muscles. It's great for immune health and cognitive function long term and things like that. So there's definitely benefits to vitamin D. But if you're self-doing vitamin D and you're taking 10 grand a day, you might very well find yourself over-absorbing calcium and doing yourself damage. So again, one of those things that you can take something good. I mean, you can take water, and you can overdo water and screw yourself up, And so there's so many nuances to a lot of this, and it depends on the person, and really just not just doing it willy-nilly, and kind of having more evidence behind what you're doing and being able to track it over time.
What does the magnesium do with if you're on D2, K3, then like most of the people say take magnesium with that. What do the three of those do together?
It'd be way bigger of a discussion to talk about each little nuance, but essentially the K2 and the magnesium help to actually drive the calcium into the bone. Okay. Yeah. Yep.
All right. Can I tell you my morning supplement routine and see what you think of it?
Let's hear it.
All right. So I do, now I'm going to draw a blank. So I start off with, so I do a K2, D3, and then a magnesium, a cod liver oil, a mineral salt in water with hydrogen, and creatine. Mm-hmm.
So I would ask you why you take some of those. For instance, obviously your mix of the D with the K2 and the magnesium and things like that.
Amino acid, a mix of amino acids.
Okay, yeah. And for instance, like with bone health, for instance, you do need adequate levels of calcium and vitamin D and things like that. And, if you are osteoporosis or dealing with weak bones or osteopenia and things like that, to really, drive home that K2 and the magnesium to really kind of get that bone building. On the other side is just the mechanism of bone building. So you have cells that are constantly turning bone over, breaking down bone, building up bone. And the mechanism for bone building and the stimulus to make those cells work is actually weight-bearing exercise, hitting, just constantly, lifting weights, hitting, running, walking, hitting, weight against your bone. That constant impact is what's going to drive that bone building physiology and get those cells active and things. Magnesium, a lot of people use, and there's so many different kinds of magnesium.
Sure.
I mean, you can use magnesium, everything from having a bowel movement to getting good rest to, supporting bone health and things like that. So whenever someone actually comes to me, I always, why do you take this or what are you looking at and things like that. Creatine has a ton of benefits. And one of them being like power, muscle power and things like that when working out and looking to gain muscle strength and improve and gain muscle mass and things like that. And there's just tons of other benefits to creatine and things.
Studies on the brain effects.
Yeah.
Cognitive.
And it does, for those who are taking creatine, it can also, artificially bump your creatinine. And people are like, oh, it's damaging the kidneys. It's not damaging the kidneys. It's a known, hey, if I see a bump in creatinine, I'll ask someone, are you taking creatine? And they'll say, okay. So I know that, jump and whatnot is not a true jump as far as, poor kidney function or something of that nature. But yeah, and then some amino acids and things like that. I would ask you, like, what's your thought process behind amino acids that you're taking?
It was just the next step in trying some different things to see how it affected me. And so far it's had good effects.
What kind of effect have you noticed?
Since I've started taking those, I just feel better. But I messed up and I started taking that and the hydrogen at the same time. But the hydrogen is supposed to be for inflammation, like internal inflammation. And I'm not sold on that one yet, but it doesn't hurt anything.
Even myself, I would actually have to look at the hydrogen aspect and look at the data on that because I'm not well versed on that myself. But with amino acids and things, if you're looking at certain types of amino acids, like you have branched chain amino acids and your valine, leucine, and things like that. When it comes to bodybuilding and muscle mass and things like that, there's some evidence there, but you can also be taking them and it can actually just, not be beneficial and waste of money, depending on how you're using them and when you're using them and things like that too.
Okay.
Yeah.
Interesting. Just curious.
Yeah.
And again, it's like, so I've been on my own health journey. I got into where I was bad shape and like feeling just terrible.
Yeah.
And managed to lose, like 33 pounds in 90 days. And then slowly started adding supplements, like, starting with just protein for the lifting and then creatine. And then like slowly started adding them and like seeing if I felt any difference. And like, I don't know what's causing it with the drink that I take in the morning with the hydrogen, the amino acids, and the mineral salt. But like, since we've started doing that, because my wife started doing it too, and she noticed the difference as well, is that like I feel rehydrated very quickly in the morning. And then I've had more energy going into the day and kind of haven't been hitting that slump.
Yeah.
And like, I've kept the diet and the rest of the supplementation the same. So something with that drink is having an effect, and I'm not sure.
One of the things that you kind of touch briefly on is like protein, for instance, and the recommended daily allowance for protein. If you look at, say an average nutrition label and things like that, it's not adequate. It's not adequate to have a substantial amount to, maintain and build muscle mass and things. And really, when you look at protein, it's hard to get really like what you can actually be best and optimize and thrive with as far as your daily intake. And a lot of people need to supplement with, a protein supplement or just be very aware and cognizant and intentional about it. Because interestingly, I had a patient a year or so ago, and she had met with a dietitian. She was very proactive as far as like her regimen and things like that. She had a body composition done. met with a dietitian or a nutritionist who said, well, you don't need that much protein that you're eating. Because she was really kind of in that, 1.2 to 2 grams per kilogram type of range. And she was like, I'm pretty sure I do. What I've looked at, and what I've done and things like that, I'm pretty sure I need that level. And the other professional was kind of arguing against her. And she said, well, all right, she was telling me, I said, I'll do an experiment on myself. And so she literally she kept all of her different macros in alignment and dropped her protein intake. And went back to her, a couple months later and had a new body comp done. And she was like, see, I lost pounds of muscle. And the dietitian or nutritionist, whoever it was at the time, I don't recall, was like, all right. Thanks you for that. You know what I mean? She was like, I'm going to prove that, like, I really feel that you're misguiding me. I'm going to prove it to you. I'll experiment on myself. I'll take the deficit. I'll work back up. But I'll show you how if I drop my protein, how it'll influence my composition and things. And that's one of the things, even just for the public to be aware, when we're looking at all these, medications and weight loss and really becoming healthier or stronger. And I think it's nice that we're actually kind of seeing a pivot, even in our young females, to where it's not that skinny focus like it used to be, when I was growing up. It's more so the strong focus. Mm-hmm. And thankfully for that. But even with just, people being so aware of, I want to lose weight, we have this obesity epidemic in America and things like that, and being on certain medications and just jumping on a scale. And a scale just tells you a number. It tells you nothing about what you're made of. Muscle is extremely heavy. And so you can actually, not be losing weight, but you can actually be gaining muscle as you're losing a little bit of fat, and the scale's not going to change, and you're going to get frustrated and you're going to give up. But if you look at a body composition, you're actually able to see, like, how much, what muscle do I have? Where is it? And where am I deficient, or where am I unbalanced and things? And look at my fat tissue and where it is. And is it more detrimental and more risky to have it here versus there? And really kind of look at it from that standpoint. And that way, when the scale doesn't really budge much, you can redo a body comp and know where you are and actually see the changes, the minor changes, in a short period of time, and know that you're headed in the right direction, or, like all the effort you're putting forth is actually showing and it's making changes versus just a number on a scale.
Yeah. And I do want to say, like, even though I take supplements now, like, the biggest change in my health was my diet. It was getting rid of processed foods and having a rough idea of my calorie intake and knowing what I'm putting in my body certain times of the day and staying on a schedule. So I just want to throw that out there, that was my biggest improvement, not the supplements that I've taken after.
Yeah, I appreciate making that point, because a lot of people might say, oh, well, hey, let me just do all of that, versus really acknowledging, taking out that processed food. It's huge. Processed food is so addictive. These food companies, they're out for profitability. They want to make money. So they hire biochemists to work for them that know the exact ratio of salt, sugar, and fat to make it addictive. And so they've done all that nuanced work. And that's why, you have one, you want another one, like, you pop and you can't stop. There's a reason for it. It's truly addictive. And then, with the processed food and things like that, and the more processed food you eat, the more you want. It's truly addictive, versus if you kind of like cut that out, it's going to be a struggle initially because you're fighting an addiction, but once it's out of your system for a few weeks, even myself, I've noted where, if I get a junk food slump and I'm craving more junk, and when I get out of that slump, I don't crave junk. I crave veggies. I'm craving asparagus and peppers and feta cheese. I'm craving, sugar snap peas and whatnot. So it's a different type of focus for your body, when you're able to kind of split that difference.
I agree. I feel like you can, if you listen to your body, you can feel what it needs. Like, when I started off at a calorie deficit, like, there was days where I'd come home and just be like, I'm craving a steak and broccoli and a potato. And that's what I'm going to give myself that today and go a little over on my calories, but it's still a healthy, natural meal. But I could just feel that, like, this is what my body needs right now. It's weird.
Yeah. Yeah. The more that you truly are mindful and kind of listen, the more you really become aware. And I used to to be honest, Randy, I used to roll my eyes at this idea of mindfulness. I'm like, mindfulness? Like, okay, great. Let me just be mindful of la, la, la. But when you're actually mindful of how you feel after you eat certain things, and you actually pause and put this autopilot world and just dartboard world, everything coming at you, and just put it on pause for a hot second, and you actually take a moment to actually reflect, you'll look and you'll say, well, I just ate that, and now, I feel heavy. I feel down. I don't feel well. There was a book that I came across called Hunger Habit. And it was this gentleman, MD, PhD, and he actually initially designed a program for smoking cessation. And nicotine is an appetite suppressant. And so typically people quit smoking, they gain weight because their appetite kind of flares. And so these people had great success with the program. It's based on habits and retraining your brain not to like go to habit versus rewiring it toward, more healthy things and whatnot, and taking away those bad habit kind of circuits, if you will. And so he noticed that the folks that had quit smoking, they weren't gaining weight. And he was like, hey, let's talk about that. And they were like, yeah, well, the program that you set up for smoking cessation, we used it for like our dietary and food habits. He's like, brilliant. There was a second book, And so when he actually started with that, he investigated and had a whole cohort and brought them through like a sequence of kind of changing what they did, kind of similar to the smoking cessation program. And even initially, he was like, what makes you eat? And everyone, like hundreds of people that he was interviewing, answered, X, Y, Z, X, Y, Z. And he was like, wow, not one of them said hunger. Every answer under the sun from hundreds of participants, and not one of them said hunger. And I'm like, wow. He's like, I thought it would be low, but I thought at least one person would answer hunger. And it just, those habits. And with us being in a world where everything's just fast paced, we got so much going on. We're just, both parents are working, you got the kids and the practice and the this and the that and all over the place. And to actually just pause, when we actually eat something, are we going to eat that piece of dark chocolate? We love it. Are we going to just toss it in our mouth and swallow it and be like, great. And grab another one? Or like, what if we were just mindful of like actually enjoying it for a hot moment? You know what I mean? Yeah. And the same thing, the gentleman that wrote the book, he had this story about how he couldn't be controlled in a room full of like gummy worms or something, like gummy candies. He's like, it was just, and it wasn't like I could eat one and like put the bag in the cupboard. No, it's like all or none kind of black and white thinking and whatnot. And so he made some details and talked about some details about mindfulness and how he just actually looked at how he felt and listened to his body. And he was like, so here I am, like eating this gummy worm. And he's like, this is kind of weird. It's like, I feel like I'm chewing on a rubber tire, and like, there's kind of a chemical taste to it. And, and just being aware of every little thing that he was thinking or seeing or feeling or, and even to the smoking cessation when he was saying, telling people to be mindful. So they'd walk outside to have a cigarette because, well, now I have to isolate myself. I'm not allowed inside. Now I'm outside and it's raining or it's snowing or it's cold. I'm uncomfortable. And I light up the cigarette and I really don't want to do this because I don't want to have this addiction. And like it actually smells bad, or it tastes bad. Like, what am I doing? Or like, like I'm missing out on everything going on inside and yada. And so instead of, just doing the habit and going and having to like hit the dopamine in your brain and okay, got my dopamine high and continuing on. And he was just really having people just be more aware of what it was doing and how they were feeling, whether it be emotional feelings or like just your five senses and all that. And how it really kind of retrained people to think about things and have different habits and be able to break those bad habits kind of thing. It was an interesting book for sure.
Interesting. Yeah, I could go off on side tangents all day about
I apologize if I have. Feel free to cut it out later if you need to.
Because it's like you talk about tobacco or like whatever form of tobacco people are using, and then you have the new studies on nicotine and the positive effects it has on ADHD. And it's like there's so many weird rabbit holes to go down with all this stuff. I could do it all day.
Oh, yeah.
But I know we've been talking about like weight loss or obesity, and like GLP-1s are a huge thing right now. Where do you fall on that?
So there are so many benefits to GLPs, but I think you just need to have that follow-up. You really need to have that relationship with a physician who is not just prescribing, but really truly stepping with you and monitoring things, and really having that continuity to make sure that they're not harmful. Because, you hear of these side effects and things. You also hear of people ending up in the hospital with something crazy going on. You also hear about this, loss of muscle mass and things. And so they can't just be with any medication. You can't just use them willy-nilly. And they're crazy expensive, commercially available. If insurance covers them, tend to even have pretty high copays on them. And if your insurance covers them, I'm finding people telling me that their insurance is forcing them to go to another dose. hey, I started at, this many milligrams, and they are telling me that they're not going to continue paying for that I have to go to the next step up. I feel good on this dose. The insurance is forcing to the next level because the insurance is basing it off this algorithm that says you start at this many this dose for 4 weeks, and then you go to this many doses for this many, this dose for this many weeks, and then you just increase. And I question that. It doesn't sound right to me. The last time I checked, I did a certain dose that was effective, and then I stopped there, with any medication. And then people getting these online. Yeah. That's what scares me. There was a recent article that came across online from a local lady in Wendell or something. And she was getting a GLP medication from an online platform. And she was feeling like it, she wasn't getting a similar effect, and she wanted to maybe increase the dose a little bit. And whoever was on the other end said, well, just double your dose. And she questioned that, and she's like, oh, geez, the way and this is my report of a news article that I read, so God only knows how true it was or the details of it. But she reports having, been like, well, that seems rather high. It's almost near the maximum dose. And the person was, just said, well, yeah, just double the dose. And even then she paused and she contacted the corporation of the online platform. And the reply that she reportedly got was just follow the doc's, follow the prescriber's orders. And so she did. And then she ended up in the ER with catastrophic nausea and vomiting, couldn't keep fluids down, acute kidney injury, and a $10,000 bill when all was said and done in this horrific event. And then it begged me to kind of question, I apologize. It begged the question, who was on this other side? Was there even a video? Because, as these online platforms blossom, I start shaking my head. Anyone can go on to Facebook and see Noom pop up. Noom initially came on the platform for saying, hey, we're going to help you change your lifestyle and how you approach food and your lifestyle. We're not going to look at medicines. And GLPs got big, and boom, Noom's like, hey, we got her. We'll send you your GLP. And so then, then the part of me that is the pessimistic, cynical side says, oh, okay, so you're going to profit off these people now, and many of these online platforms, I've seen certain threads say, oh yeah, well, to be a part of this platform, you're paying $200 or $300 just to be a part of the platform monthly. And then you also have to pay for their compounded GLP that they're selling or they're making or they're distributing. And I just shake my head and I'm like, what's going on here? And now the FDA is coming down on compounding pharmacies as far as their different licenses and who they supply to and the 503B versus A. And it's just a nuance on the pharmacy side of compounding, whether they're able to supply to an office versus to the patient themselves and things. And
that's a patent issue, right?
And it worries me. It's everything from a patent issue to really, there's enough need out there that I don't think these pharmaceutical companies are going belly up by any means, but there's the access issue. And honestly, I think of it as a dosing issue because I do work with compounding pharmacies in my office. And so I can order compounding medications like GLPs, and instead of starting at a, X dose, I can start smaller. So, and I can, increase by a half or, milligram instead of increasing by just 2.5 milligrams or increasing by a substantial amount when the patient might not need that. And to be able to say, oh, okay, you're having some of these side effects, but it's definitely helping. Let's, do 2 injections a week and just, take that dose and split it. You can't do that with these commercially available. So, there's a lot of other things that compounding can be helpful with. And a lot of the compounders, there's this bad rap on compounding, oh my goodness, you don't know what you're getting and this and that. But the APIs that they use are FDA approved. So the included pharmaceutical ingredients are FDA approved. It's just the end compounded product is not necessarily gone through the FDA, which is, again, patient information and not everything. And the other worry is that you go online and there's umpteen YouTube videos of hey, this is how to drop your GLP-1. If you go to this many units, then it's this many milligrams. Yeah, at that concentration that you might be referring to, but the Joe Schmo at home who's following your video and is like, oh, that's how many milligrams I'm told to take, has a different concentration and then screws themselves up because they weren't working with a physician who was able to teach them or work with them in person or even see them in person. And all these online platforms just left and right. I think that's really where the FDA is trying to crack down, not necessarily the compounding for like the physician's office that's actually following up appropriately with patients, but either the physician's office who's just willy-nilly just giving everybody in a GLP that walks in the door, or these online platforms and things like that, because it's scary. And some of these online platforms aren't even using video. They're asynchronous. Like, hey, so-and-so, I would like this medication. Okay, well, do you have this history? Oh, can I do the medication with that history? No, I don't have that medical problem. No, I don't have high blood pressure. No, I don't have that. I don't have a history of that. Never had pancreatitis. Okay, well, these are the risks. Oh, sure. Okay, I agree with those risks. There's not a true back and forth conversation to really evaluate. Does this person actually understand what I'm telling them? Can they comprehend and make a true decision adequately based on the side effects that I'm talking about? As well as, is this person even obese? My worry, Randy, my true worry, just human to human, is that there's some poor 20-some-odd-year-old anorexic on the other side of that saying that she weighs 300 pounds and is getting some GLP-1 sent to her apartment because of a disorder that's not being treated because of mental health issues. And who knows? Like, that is my worry, honestly, that people are abusing this medication and not for good ways, or they're not being tracked. So they're not, they might not be eating the adequate protein or exercising well and making the lifestyle changes. This medication is a tool. It's not the end all be all. You are going to harm your body. You're going to walk away losing muscle if you haven't done your part and someone hasn't verified and been and stepping with you doing that part. You can't get that from an online platform. You can't get that from even sometimes a 15-minute little in and out visit. The only way you're going to know that is, someone drops weight, looking at them on a scale, you can say, yeah, you're dropping weight. You can ask them if they're doing what they're doing, but they're just going to be happy to drop the weight. They might be dropping tons of muscle mass. But unless you look at a body composition, you're not going to know that and things. So, there's so many, with any medication and anything we do, there's always risk and benefit and things, but it's really about, are these people getting it from the right sources and having that follow-up and having that relationship where when they're having an issue, they can talk about it before it becomes some crazy catastrophic ER, hospitalization visit, type of thing. It's worrisome to me, to be honest.
Yeah. That's why I don't know a lot about them. I haven't done much research or listened to a whole lot of stuff on it. I have heard that it causes muscle loss. And then I see, again, the people online, there's people taking it that it's like, is that really the best option, or are there other options to be taking it?
Yeah.
Like, I guess, what is a GLP and like, who's it made for?
So GLPs, the studies behind them are astronomically awesome. They are incredible medications, and there are, the first lines that mainly do the GLP or glucagon-like peptide receptor agonists. Then there's ones that also influence the GIP receptor, and there's other ones that are actually in research. I have a patient that's in a research study with one that's like a medication, GLP, GIP, as well as a third receptor. And these medications do a ton of different things in a ton of different ways. Like they really regulate a lot of the hormones around, glucose and glucagon and insulin levels and things like that, and insulin sensitivity and everything from like how slow or how fast your stomach empties so you feel full longer and things. And there's a lot of benefit to these that we've identified when it comes to kidney health and cardiovascular health and cardiovascular risk. And also even these more anecdotal, when you look at the community of folks suffering from different inflammatory conditions, of reduced inflammation in folks. And so there's a lot of data out there and a lot more studies hopefully coming out that aren't just focused on the weight aspect of them or even the cardio and kidney benefits and things like that. To be honest, I've had tons of patients throughout the years. And I don't have a ton of experience with these medications for folks, but I've had numerous patients in the, if you think of percentage of my total patient base that's been on GLPs and things, I have a ton of folks who say, I can't describe it. My body felt so inflamed before. I felt heavy, not just my weight. Like on this medication, like I might be stable on weight or I might be, I got to my goal weight and I've reduced my medication just to help stabilize me there and things like that. And they just feel like even at tiny doses, they feel like this inflammation is gone from their body, There is a condition called lipedema, not lymphedema, but lipedema. And it's in essence, to kind of keep it just simple, it's like a dysfunctional fat cell. They're enlarged, they're dysfunctional with a ton of different ways. And one of the things is very painful. So someone with lipedema, if they have these abnormal fat cells on their arm, even a blood pressure cuff can be extremely painful. Just, touching your legs where these fat cells are can be extremely painful. And people have reported being on low doses of these GLP-1 medications and not having that pain of these dysfunctional cells. So there's a lot that we don't know, or even perhaps, areas where these receptors might also be involved that maybe we don't have that information about. But these are wonderful medications and have tons of uses and tons of benefits across the board, weight aside, everything from sleep apnea to cardiovascular benefit to kidney benefit. But they have to be used the right way, and you almost say, they cause, loss of muscle. I would caveat that and say they can cause loss of muscle if not done the right way, and so when we look at the pros and cons, it's always a big discussion. There's tons of benefits, but you gotta use them correctly.
Another one I wanted to touch on, which I mentioned earlier, but statins, because I'm hearing mixed stuff about that the studies on it are a little, and this is just what I'm hearing, and that's what I want to ask you, is that the studies are a little murky, that they don't necessarily show an extension of life, that a good diet could extend the life more. And I usually find that when I'm hearing those kind of statements, that the answer is somewhere in the middle.
Yeah.
So I'm just curious about your take
thoughts on statins are, so a lot of people don't know that, cholesterol in our bodies, like the LDL, bad cholesterol, that kind of comes from two different mechanisms. Your liver makes LDL, but then you also can consume and absorb LDL. And so some people can, two different people can eat the same thing and one person overabsorbs it from that mechanism. And certainly for those folks, dietary is going to have a big influence. Now, I've known people who have excellent dietary, habits and things like that, really don't eat a morsel of, bad food, whole foods, not a morsel bad, those kind of things. And I'm exaggerating to a certain extent, but they have crazy high LDL. Why? Because genetically, their parents passed them the gene that turns on, more than it should, the production of LDL. And so, statins for them is definitely going to help in that situation. Now, when we just say, okay, your lab's this, and poof, give a statin, versus again taking a step back and saying, okay, let's look a little closer. Are we overabsorbing LDL? Are we producing too much LDL? What's the better option? What are you doing in your life? And making those changes, because I would argue, I'm right there with you. If we do lifestyle changes, I mean, if you were to tell anybody, if you were to look at any disease process, dementia, the best thing for prevention of dementia is diet and exercise, appropriate diet and exercise. And the statistics are strong for that. It's not just, there's a little bit of stats out there, like, there's a pretty good correlation, but like, boom, right there as far as dementia risk and cognitive risk. And the same thing when we talk about medications like statins and things, some people, really we should be looking at lifestyle. Can you kind of take that same stance and say, okay, well, if you're not willing to do lifestyle, can we do something to help you? Or some people are those people who say, I like my beer, I like my burger, I like my fries, not going to do a darn thing. And there's benefits of statins that are independent of just cholesterol lowering. One of them being inflammation, vascular inflammation, and another being like plaque stabilization. There's plaques there, we can help stabilize them so we don't break off and have downstream effects. And really it's about looking like at these studies and the population that they looked at, and looking at, are there certain biases in these studies, or when we look at these studies, are they showing, morbidity and mortality benefit, or are they looking at a certain population, say, that has, increased production versus not? And so there's really, how does this study apply to me? If there's a study looking at something and it's referring to, a completely like Asian cohort and, people who are pre-diabetic or diabetic or X, Y, and Z, and they're looking at all these different things. And like, is that you? Can you apply that to you? Is it really just one for one, or is it not? And, you know, as a white person, as an African-American or things like that, like, what's the population of the study, and is it really transferable to me and things like that? And just really kind of looking at the data in more detail.
Okay. One more class I want to touch on, and this is a little different one, but it's real popular right now. It's peptides. Mm-hmm. And I know an issue that we've had with accessibility. My daughter, she travels the world doing jujitsu. That's what she does. And she's at a very high level. She had a bad injury. She had a Liz Frank injury.
Oh, goodness.
And, which is it's a pretty devastating injury requiring surgery. And talking to some specialists, like peptides was a real option to help her get back, because she broke her foot, continued training for almost a week before she got in to see somebody that told her what was actually wrong. And they were like, we don't know how you're walking, let alone fighting on it.
Yeah.
And then she had her adult debut in Portugal in 3 months. So we found the right people to help us achieve that goal. But one thing that we were told that could help us was the peptides. She was 17 at the time. And like, I went to everybody I knew, and like, nobody felt comfortable prescribing them to her.
Yeah.
And I wasn't comfortable going, like, they gave me websites and stuff, and I wasn't comfortable going online. So I feel like that's something that really could have helped her that we didn't have access to.
I mean, that's a great point. My knowledge on peptides is very limited in just, you know, details of the peptides and things, but there are huge benefits with peptides. And a lot of it comes from injury, rehab from injury. The anecdotal data that I can speak from with people that I know who have used peptides and things like that, there is great evidence, you know, and it really boils down to, you know, being there and stimulating the right aspects of your body to, you know, your body naturally will heal. But when we're looking at timeline or the strength of that healing and things like that, peptides have a huge place. Now, there's very few, if any, you know, like, there's some peptides that are commercially available, but they're not indicated for those types of uses. You know, they're indicated for, you know, different, completely different medical uses. And so right now there's this like online market of getting peptides from other countries, or who's the supplier, what's the veracity of that, you know, how tainted or not tainted, or what are you getting into kind of thing. But peptides have a huge, huge role. And there are compounding pharmacies that work with peptides and things, but it's definitely a new venture. There's a lot of research around peptides, and a lot of the components really are just research based. So if people are using them or trying them, they're using themselves as kind of a guinea pig, if you will. And, you know, they're not without, you know, potential complication and things like that. One of them being, you know, if you are stimulating or using certain peptides that, you know, influence growth hormone and things like that, are you predisposing yourself to cancer and things? And again, there's huge benefits to those. And I think that it's an area that, you know, research is definitely leaning into, because even when we look at like GLP-1 medications and the different types of medications and really any kind of protein is a peptide, you know, now we're taking a protein that's many, many, many amino acids, and we're taking just a small chunk of that to be useful. Looking at that, I think, is really going to be kind of the next step. And really, you know, there's these different terms around it, you know, longevity or regenerative and this and that. But really taking parts of our bodies that we know are so helpful, and really kind of use them for detailed things. And it's going to take people kind of stepping outside the box. I think that's why it hasn't gained national traction or true FDA traction, because there's so many questions out there, and it boils back to liability. You know what I mean? This whole litigious liability, where's the liability lie and things. And so that's why, you know, being able to, you know, find a study or work with a study, or, you know, if you're that, you know, into it, to actually find a reputable physician in another country that's doing trials on it or looking at it and things like that. But that's definitely, I think that's kind of the next step that we're heading into. I think that, like, to a certain extent, the GLPs have kind of started putting that out there, you know, and so many people, when they're just on top of their own health and those data-driven health folks out there, kind of like yourself, that, are saying like, what we have now is not helpful. Like, we're strapped. We're in a situation, we're kind of strapped. What can we do to really help people rehab? And this can be applied. I'm excited for peptides because if we look at this more, it can be everything from injuries to maybe burns to rehab, or, stimulating our body to be able to regenerate certain cells that can, improve people's lives without having to take drastic measures. There's so many different nuances it can be used for. So I'm hopeful of what the world and the research aspect holds. I don't know all the details, but definitely I'm in the process myself, actually, of getting more information and learning more about the peptides that are out there and the benefits and certain risks and things like that, and where they're most helpful and how we can use them the right way.
Yeah, I don't know why I enjoy like diving into certain topics like this. I get into it and like just absorb as much as I can. My latest one is Ibogaine. I don't know if you've heard of that.
That one I have not, no.
So it's for treating addiction and PTSD, is where they're seeing the biggest results. They're talking about like the first treatment is like 80% success rate. And if they do it twice, it moves up to like 89 or 90 some percent.
That's incredible. I mean, that's life-changing stuff. Yeah. You know what I mean? To be honest, I mean, I know that through my own medical issues and struggles and things like that, if you're at a point where you're like, all right, my life looks like path A, or I can take a risk and go path B. Like, this A is looking pretty crummy right now, and my quality of life and this and that, it really begs people to say, you know what? Like, let's offer this up to select people who have done and spent, the last 5, 10, 12 years in a situation where we don't have things to help them and see what we're getting. Because, especially when you look at how addiction from anything, you have everything from, children who have psychiatric addictions to self-harm to addictions of, hard drugs and alcohol and tobacco and food. And it can be life-changing. And I think that we just need to kind of say we're willing to step outside of that comfort zone.
Yeah. And like you said, it's taken a few people to do, test themselves and then bring it back, going to other countries to do it and seeing the results from it. And that's what I'm kind of watching that unfold now. They're talking about doing trials in certain states to see. So it's an exciting one.
Yeah, it's exciting. And I think we always have to be cautious too that, with anything, there's always another flip side of that coin, Yep. Even if you look at, some of the situations we find ourselves in now, like opiate epidemics, we were all on board. Like, this is really great. It's not addictive and this and that. And, the whole 9 yards. And then come to fruition, we're on the other side and battling another storm. So we need to be cautious, but then know where we can kind of start applying this and maybe getting more information and things. So absolutely.
Awesome. Thanks for, appeasing me with a bunch of information.
Absolutely.
But I want to end with talking more about your business. One question is like, what does your type of care have for small business owners? Like, are there opportunities for small business owners?
Absolutely. And that was almost like one of our main focus points initially is, there's 2 ways to become a member and to really get a lot of the benefits. And we work with individuals and families and things like that, but small business owners, because when we launched our business, like I mentioned earlier, we were like, what? And there's a lot of small businesses that can't afford health insurance. And maybe they did at one point and they can't any longer, or, they can't take that monthly, like, wait, now it's the inconsistency and the transparency of pricing is just so convoluted. Working with a direct primary care office is fantastic, where, you might have employees who don't have insurance, or maybe they're on their employer, their spouse's employer plan or things like that, or they just can't get in the door even. You can have the best insurance, but if you have to wait months and weeks to get seen and your visit is a strap, 10, 15-minute visit that, boom, 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 and out the door, and you're not getting the care that you really feel you deserve, it can be a huge benefit. And small businesses they can afford this so easily, especially compared to insurance, especially compared to like a lot of other health or wellness benefits. And we work directly with small businesses, and there's no minimum employee number and things like that, where like the business can orient it and work it however they want. If they want their employees to pay a portion, or if the business wants to, we work and we have a slightly lower rate for a monthly membership for businesses. And that wellness benefit or health benefit, or however you kind of want to term it, can be a big sticking point. And a lot of businesses who have used DPC, if you look at the stats, up to 80% of their employees will not leave because of that one benefit. Because, it helps attract quality employees and retain quality employees. And many people might not even realize it's a great benefit until they even experience it. And then they're like, wow, how did I live with that before? Without it, how did I do it before with, a quick visit and in and out and, being seen at urgent care and ERs because my doctor's office couldn't see me and things like that. And so it's a huge benefit to small businesses.
What's the process like for a new patient? Like, I know you mentioned that you spend extra time with them in the beginning, and then also like, how's it work with if they need labs or if they're out of town and then they need to go see a doctor like that?
Yeah, huge benefits. And it's as easy as like, if people are unsure if we're a good fit personality or even just the model itself and have more questions, they can easily go onto our website, sign up for a meet and greet. It's free. It's no obligation. And then, it's for an individual joining or a family joining, it's as easy as just join now, putting in your information. When that happens, they get an email automatically to download the app. There's an app that goes along with our EHR. There's also a patient portal for that as well. And they get a direct message from us with kind of just like hey, welcome to the office, kind of the streamline, what to do next and everything like that. And they can even, right from there, schedule their own first visit. And that first visit, like I say, I do spend extra time at that first visit, and I block it that way so that I can get to know health information. I can get to know each person as a person, what they do for work, what their support system looks like, what kind of family life is like, where their parents are, siblings, and pets at home, and, their goals and their wishes or their previous experiences or preferences. And then from that, each person is so individual because some people have not seen a doctor in 25 years. Some people have, just gotten done with a physical and been like, what was that? And I need better. And so really it just, at the end of that visit, really it's like, okay, what are your goals? Where are we going to go next? Hey, you have insurance? Well, I can take advantage of that. And while I don't bill insurance, I can send your insurance information with a lab order. So if we know insurance with these certain codes or diagnoses or whatnot will cover these labs, I can send it off to the lab with, insurance, or we can, if there's other labs that you want to look at that we know insurance is going to reject, and then you're going to end up with that catastrophic bill, we can just pay $10, $12, whatever, and get you those certain labs that we want to look at and be more proactive or preventative and things like that. And then we can actually send them in the same, same labs, 2 different orders, same lab draw in the whole 9 yards, and send it off. And I draw labs in the office as well. And so that's pretty much like the first step. And then we just say, all right, like, when do we want to meet back, or yada, yada, and go from there. And so that's really just the easiest way to sign up for folks.
Awesome. What, is there anything that we didn't talk about today before we get into our closing that you feel like people need to know?
I don't know. One of the big things is really just with the cost of everything, especially the transition of this year and people saying, oh my goodness, my insurance went up hundreds of dollars. I can't afford it. Those kind of things. Folks that have HSAs, in the past, it was kind of a gray zone in the law, but people can use HSAs toward membership and to kind of get that, that triple tax benefit of using HSAs toward DPC membership. It's now, there's some caveats, like an individual up to, I think, $150 or a family up to $300 can be used with HSA. And so that can be done. I think that's probably one tidbit that comes to mind. But otherwise, learning more about DPC, I'm happy to meet with people and educate them and just give them the background, not only of how my office runs or things, but just in general, the benefits and pros and cons and things like that, just to educate people and let them know about it.
That's great. Couple rapid fire questions before we close out. Let's see what we got here. Do we have anybody on there asking anything?
There's 2 people, no questions.
No questions. All right. Most misunderstood thing about healthcare.
That's a great one, actually, because I had people established recently that was like, you get kickbacks, don't you? And I was like, who? No, doctors don't get kickbacks. Physicians do not get kickbacks from anybody. There is no kickback for prescribing a medicine or no, it doesn't happen. Absolute myth.
Most overused medication today.
That's a good one. I'd probably say your NSAIDs, your ibuprofens, because people use it and they don't realize that if they use it too much, they can actually damage their kidneys. I'd probably say over-the-counter medication somewhat to a certain extent. Absolutely.
Or one day it might just try and kill you. That's
Yeah.
what happened to me.
Yep.
I took it every day for pains. Then one day I just went into full anaphylaxis and like,
Goodness.
yeah, it was crazy.
Yeah.
Most underrated health habit.
Like good health habit or bad health habit?
Good health habit.
Most underrated, hydration. Staying well hydrated.
One thing that you would fix in the healthcare system if you could tomorrow.
Tomorrow. Get rid of insurance.
And then what's more important, growth or lifestyle business?
Say that one more time.
What's more important from a business aspect, growth or lifestyle business?
Lifestyle. Because if you can't survive and have a good balance, then the business is not going to be fruitful. Yeah, for sure.
Tell everybody where they can find you or how they can get a hold of you.
Absolutely. Online is as simple as it sounds. The name, trueinsightdirectcare.com, spelled just as it sounds, the usual way. There you can do a meet and greet. You can put in information. It's just like contact us kind of form, or simply giving the office a call. And honestly, if I'm not with a patient during the day, I'm the one answering the phone, which is funny because people will call and be like, what? Who? They didn't expect to get the doctor answering the phone. And yeah, it's easy to get a hold of us. Email as well, info@trueinsightdirectcare, and we'll get back to you and touch base.
Awesome. And we like to end every episode the same way because once I figured out my definition, it changed how I run my life and my business. How do you define success?
Success for me is really relationship based, I would say. Definitely. If you can make a difference in a relationship, that really extends beyond just that one person because they see a benefit and that trickles down into their day-to-day life for sure.
Awesome. Well, that's a great way to end it. I thank you so much for coming in today. I thoroughly enjoyed it.
I appreciate it, Randy. Thank you so much for having me. I'm glad we were able to connect.